Good afternoon. My name is Susan Lynn Osterly. I'd like to welcome everyone to the 12th convening of the Low Value Care Task Force. Before we get started, I would like to go over some housekeeping items. We request that you please add your affiliation to your Zoom name. The directions are up on the screen. You click Participants button at the bottom of your screen to open the list. Hover over your name and click on the More drop-down button. Click Rename, and then please include your first and last name followed by your affiliation. As always, we would like this meeting to be as interactive as possible. When you would like to ask a question or make a comment, please raise your hand. To do that, you can click the Reactions button at the bottom of your screen and select Raise Hand. If you don't have a Reactions button, as I don't, you go to More at the bottom of your screen and click on that, and reactions will be in the list that pops up from there. And then you click that and you will see Raise Hand. When it's your turn to speak, please remember to unmute yourself and turn your camera on. When you are not speaking, please have your camera off and keep yourself muted. After speaking, please lower your hand. And now it's my pleasure to hand things over to Michael Chernew.
Thanks so much, Susan Lynn. I am thrilled to be here, thrilled to welcome you all. As many of you know, this has been a long journey that Mark and I have been on to try and figure out how to make the healthcare system more efficient overall and make sure that people get access to the care that they need and we don't waste money on care that they do not. In order to make this meeting possible, and Cliff will go over the agenda in a minute, but I think you'll agree once he does, it's an amazing agenda with amazing speakers. We need support, so I want to really thank from the bottom of my heart our supporters. So that includes Silas from Johnson & Johnson. Silas, I think you're here, but I haven't followed everybody now who's joined. But again, it's been a long journey with you, Silas. You've been there since the beginning. We could not be happier. Merck's also been another long-time supporter. And so I want to thank Sharif and the team from Merck for everything that they do. We really appreciate it. And lastly, also I want to thank Ali and our friends at Pharma, who have really been outstanding in supporting the efforts that have gone to try and make sure the healthcare system is efficient and provides people with the care that they need. So again, Ali, thank you. I could not be happier and more excited for today's agenda. So I'm going to turn it back to Cliff, who will go over the agenda and we'll get right to it. Cliff.
Mike, thank you very much. Very pleased to be here at our 12th convening the Low Value Care Task Force. In addition to a great core of folks that have been on since the very beginning, we've had great additions of people from across the healthcare sector spectrum. And it's just always great to get caught up with folks insofar as progress they've made to get after low value care. As Mike said, we've got a wonderful agenda here. It's all set up. Be delightful for me to introduce in a moment, a little while, Will Schrank, who's going to address low value care from a health plan perspective. And I think he'll bring a few health plan perspectives along the lines there. Maybe toss in a few policy insights along the way, who knows. Thereafter, Katie Keith from Georgetown is going to talk about the implications of Braidwood versus Becerra. This is a very important development that is going to affect or has the potential to affect what we're trying to accomplish with low value care. We're very interested to hear what Katie's got to say about that, and I imagine some of you all will have some reactions to that as well. We'll take a short break, and then from Penn, Aaron Schwartz will come on to talk about low value care reduction, and in particular, certain challenges and opportunities that he has discerned and will share with you. There's some really hot points in there, I might add. After that, Katie Spangler, who really just bird dogs this issue in and out, is going to talk about some policy options to reduce low value care. Katie herself has been involved in quite a few of those policy options. And of course, she'll be joined by Mark Fendrick, who has really helped to initiate and was really sort of at genesis of some of these as well. So between Katie and Mark, we'll get a great update along the way. And then we'll finish off with some next steps and adjournment. So plenty to do between now and 4 p.m. Eastern time. That is our agenda. Want to go next to an important part of our agendas, as always, is the introductions and actually member updates. And so I've got queued up a couple, 3 people that I'm going to ask to provide just in a minute or two self-introduction and why it is you find yourself here attending for the first time. I'm planning on calling on Randa Deaton, Mohammed Saeed, and Aditi Sen. If there's anyone else I'm missing, please put something in the chat so I won't overlook you. So let's just do that now. Randa from PBGH, how do you find yourself here today?
Well, thanks for the introduction. I know that my predecessor, Lauren Vella, served on the VBID committee, and Bill Kramer had recommended that I re-engage PBGH on this committee. So anyway, I'm a big fan of VBID's work, and I know a lot of the people on this call, and have talked several times with Mark Fendrick and have followed it. I used to be the CEO of the Kentuckiana Health Collaborative, and also worked at Ford Motor Company and HR and benefits for 25 years. So anyway, I'm delighted to be here, a fan of the work, and happy to be representing PBGH here today.
Thank you, Randa. And of course, PBGH has been an integral member of this all along. Mohammed Saeed, can you sort of introduce yourself and remind us and tell us how it is you find yourself here today?
Thanks, Cliff. Hi, I'm Mohammed Saeed. I'm actually a cardiologist at University of Michigan, as well as a chief medical officer at Health at Scale. So one of the co-founders of Health at Scale. So we are a company based in Silicon Valley, founded by academic and clinical faculty with the mission of using machine learning and analytics to improve healthcare delivery. We have a particular interest in how we can use machine learning to reduce low-value care. I've had great conversations with Mark Fendrick and Mike Cherney about this. And, we are here to learn more about low-value care and see how we can be most impactful.
Mohammed, just before we move on, I just want to interject a quick question to you, and that is, whenever we hear about machine learning and using AI applications on issues that have to do with healthcare utilization and so forth, there's always that possibility in the background or concern in the background that your training data in machine learning and your evaluation data may not be sufficiently representative of your two true target populations. Are you thinking through that at all insofar as how your machines are in fact learning and based on what data?
Yeah, so we have, very massive data sets, over 150 million patient lives that we think is, quite representative. But on top of that, I think this is where we throw in some really big academic horsepower. So one of our other founders, John Guttag, was the chair of computer science at MIT. And we really focus exactly on this question on how do you build machine learning algorithms that can actually work with smaller data sets, but still have good accuracy and provide very useful information that it would be representative of the patient population, but look at each patient as an individual, what makes them different, and try to identify what is high value versus low value care for that patient for that context.
Got it. Okay, just hope you don't mind. I just wanted to slip that question in because it's always on everyone's mind when we're thinking about machine learning AI applications. And if you're trying to find high or low risk populations, we want to make sure that we're sufficiently representative. Okay, I don't see, Aditi Sen, are you on yet? I don't see you on just yet. I do see a couple of people who are calling in. I don't have names on them. Okay, am I missing anyone else who is what we'll call a new member or new attendee? Am I missing anyone thus far? I'm going to check my chat to see if I see anything there. Not yet. Okay, thank you very much. If we missed you, we'll try to capture you later insofar as a new member or new attendee. Want to get some member updates at this point, so let me kind of cue this up. So before we go to Beth Bortz, and I'm queuing you up, Beth. Beth Bortz is going to lead off in just a moment. I do invite others who may want to provide a member update. I'm going to probably call on Carol Huffman as well, if she doesn't mind, from Emblem. So Carol, this is a fair sort of cue for you as well. But if there's anyone else who wants to offer a member update, I mean, please let me know. And then a little bit later in this hour leading up to 1 p.m. Eastern, I've got a slot set for Denise Giambalvo, who's going to talk a little bit about, well, actually, she's going to talk about some things that have been occurring at the Washington Health Alliance, having to do with imaging and low back pain and so forth. So Denise isn't on now, but she's going to be ready toward the back end of this hour. So if you've got a member update, let me know about it. Put it in the chat. I'll try to get to you. We'll go to Beth, followed by Carol Huffman. Beth, what do you have for us, Beth Bortz, longstanding member of this initiative?
Good afternoon, Cliff. Can everybody hear me okay? Great.
Very well.
So I'm happy to be back with the group. I have two initiatives underway that I just want to share brief remarks. The first is our Smarter Care Virginia work, which I think those of you that have been on before, you've heard me talk about this. This is our grant from Arnold Ventures, where we have 7,000 clinicians in the Commonwealth of Virginia engaged. The good news is that despite the challenges that the pandemic has thrown at us, all 6 of our health systems and 3 clinically integrated networks have stayed engaged in the initiative. Our active intervention period will end on December 31st, and we then have a 1-year period of pulling all of our final data so that we can share with you whether or not we were able to achieve a 25% relative reduction in the measures that we selected. Initially, we selected 7 low value care measures, all of which we were able to measure using the Milliman MedInsight Health Waste Calculator and our state all payer claims database. Our group actually, despite all the things you're hearing about burnout and staffing shortages, our group actually decided to add 2 more measures to their work for 2022. So we're now working on 9 different measures. The 2 new measures both deal with low back pain. So they wanted to address imaging and opioids for low back pain. I will tell you the impetus for that really came from our business community, who our employer task force asked that those be added, and the clinician community agreed. And they have actually generated quite a bit of support from the primary care community. They really are eager to tackle those too. So the project still underway. Our next big challenge with that is going to be the evaluation, because as you may recall from when I shared this several years ago, the initial evaluation was to have been a step wedge. COVID kind of changed our plans. We weren't able to roll it out that way. We are now very fortunate to be using the ARC Compendium of Health Systems to help us establish a control group. And then we're working on our attribution methodology now. One of the things that we are realizing is that attribution will actually probably change for each of the 9 measures selected. So working on that, we should have available to share with this group probably in the next month or so. Our assessment of the impact of COVID on low value care in Virginia. Our research team added that to their to-do list, and they're just finalizing those results right now. So in general, just we keep plugging along on Smarter Care. The other piece of the update that I have for all of you relates to the work that we are doing with the Starfield Summit, the 5th Starfield Summit. We are doing this in partnership with Mark Fendrick and the VBID Center, as well as with the American Board of Family Medicine and their Center for Professionalism and Value. We received funding from ARC to hold 4 virtual sessions focused on low value care and primary care, and really trying to build some consensus across primary care as to their role in addressing low value care. Where we are today, we've held all 4 sessions. We have one more survey to go out to the 50 really VIPs that are part of that group, and many of you on this call are part of that group. That survey we expect will go out in the next week or so. That will help us final a no value list. Building off of the work that Altarum has been doing to develop a no value list, we are trying to get consensus from our group about primary care's role in addressing a no value list for primary care. The other thing that we have done is we have put together a future research agenda for primary care and low value care, and we have garnered consensus around that. There's really 3 buckets there. The first is a number of questions around improving low value care measure development. The second bucket is understanding low value care influencers. And the third is making low value care reduction actionable. And we are excited to share that research agenda with ARC and hopefully then start to generate some funding to address those questions. And then finally, we are working right now to submit a letter of intent to the American Board of Internal Medicine Foundation for their Choosing Wisely RFP to kind of continue the work specifically around the no value list. So that's my update, Cliff.
Good gosh, Beth, is that all?
That's all.
Wow. You've just been such a leader in this. I have to ask a question, and it has to do with the depth and longevity of your community and state support. So you mentioned earlier the business community. Do you have any insights about how, or lessons about how you've engaged the business community and how you've engendered their ongoing support throughout this?
You know, the business community, I will say, has been, you know, truthfully the toughest nut to crack from day one for us. And some of that has been a challenge with data. You know, we are very much a state that has been focused on step one is show people the data. Because once you start to show them the data, their desire to get engaged increases significantly because it's hard to deny the data. The challenge that we have had is that through ERISA, you know, our large employers are exempt from submitting data to our APCD. And so it's harder for us to show them the data. You know, we can show the state employee health plan, for example, their data, or our state Medicaid agency, their data, because they're required to submit. But, you know, our large employers, it's a much harder task. We've really worked with them to encourage them to ask that of their health plans, you know, to show them the data. We've made some progress there, but it's still challenging. So really, you know, we've had to rely on showing them regional and statewide data, not their own data. And that's helped. But I would say that to me is the next, you know, frontier is trying to figure out how to really get them to see their own data.
That's such a great point, because you actually mentioned this several years ago, that you've got to kind of almost put up a mirror to the employers to say, here's where you are, and there's a lot of upside to doing this,
right,
to addressing low value care, but they need to see it in concrete terms. And you've just done as well as you possibly can, kind of showing the broader statewide data. Maybe that gives them a basis of comparison. Just another question, if you don't mind.
Oh, go right ahead.
And I'm going to get to Katie in a second. For the uninitiated, tell folks who Starfield is or was. We
sure.
Old timers know her, but maybe not everybody knows who Barbara Starfield was.
Yeah, so Barbara Starfield is really the godmother of primary care, I guess, you know, who identified kind of the 4, you know, core components of primary care. And in recognizing her work, the American Board of Family Medicine, in partnership with others, launched the Starfield Summits. They have addressed, you know, a number of things. You know, they're kind of the action agenda for primary care. And so we saw that opportunity and went to them and said, could we bill, you know, this work around low value care as the next Starfield Summit. And
Great.
we were very fortunate that they agreed to allow us to use kind of that billing, because it gives us kind of another level of credibility, for the work that we're doing.
Well, good, thanks. Old timers appreciate that, and some folks who didn't know Barbara will as well. Katie, did you have a point to raise?
I had a quick question for Beth, and Beth, I can follow up with you offline on this too, but given that we do have a lot of the employer benefit consultants and some carriers on the call, I wanted to just gauge your reaction. I'm really sensitive to your point about large employers not giving you their data and the Go Bay case and kind of the fallout from all of that. I wonder if there would be a way to just, to your point, like work with the insurers, to ask the insurers, particularly the big ones, to give you the data on behalf of the employers. And maybe there would be something in there, I know we all have demo fatigue, but like, what about some type of like CMMI demo where the care, I don't know, just trying to think creatively about a way to get you the data in a way that's not burdensome on the employer.
I would love to discuss that with you, Katie. I mean, we've had meetings with some of the, the vendors, the benefit vendors about that. We've had meetings with the plans. It's a little bit tricky because, they always fall back on, they don't want to have to purchase the Milliman product. Milliman has been very gracious in trying to work with them. I would say, I think sometimes that's not the real reason. But I'm happy to talk with you offline and see if we can come up with a creative strategy, because I do think that's a really important piece for us.
Yep, okay. Love it. Thanks, Beth.
And thanks for the question there, Katie. Ever so briefly, Mike Chernow and Cheryl Larson. Brief points, please.
Yeah,
Mike?
I was going to say in response to what Katie said, of course, many of the carriers on the line, Aetna, Cigna, Humana, a bunch of others, actually have already gotten the tool. And it's really a question of how the employers can support them in using the tool, because I think we don't have the time now, but if you were to reach out, we'll have John Keats talk from Cigna, but if you were to reach out to those carriers, they are actually quite active, at least the ones that I know, in measuring and reacting to low value care in a range of different ways. And it's really a question of how we solidify those ties and contract for that type of work, because I see that happening, at least on the set of carriers on this call. And we have really some of the biggest, most important ones in the country here. So that's my brief comment.
Great insight, Mike. Thanks very much. That helps others understand this issue as well. Hey, Cheryl, what do you have?
Hey, I'm trying not to, have an anxiety attack here. Beth, that was an amazing presentation, and I am so proud of you and wanted so desperately to better engage, and I had a tough year. But anyway, I feel like we're on a precipice where we are ready to say we're done. We want our data. It's our data. The law says it's our data. Give us our damn data. We shouldn't have to pay for it. I think that, everybody's holding our data hostage as a way to make money. And, any of the carriers on the call today can call me up or text me and yell or whatever, but enough is enough. And we have got to transform healthcare. Nobody wants to make less money. Cliff, I promise you, I'm almost done. Something has to change. And so my coalition colleagues on the call today are right there with me. And Beth, we're frustrated by the apathy of some employers as well. And so we're trying to move along with that. And so if we ever want to have a separate call on that with our coalition colleagues, we're happy to do that. Thank you so much for giving me a moment.
Thank you, Cheryl. Giving you a moment is never a waste of time. And actually, the issue you've raised and in reaction to Beth is something that needs to be perhaps an agenda item here, or something that needs to be pushed kind of up the priority list on policy changes. So that's very, very helpful. Beth, thank you so much. As always, you elicit responses all over the map. We really appreciate that.
Thanks,
next. Thank you, Beth. Don't go away. Carol Huffman from Emblem, if you don't mind coming up next, and I'm going to give a hint to Jason Spangler. Jason, we want to hit you up in a few minutes as well. Carol, what do you have?
All right, so I'll just talk about one initiative this time that we've been working on. Last Friday, I was invited to speak on a panel at the New York Association for Ambulatory Surgery Centers. It was their annual conference. And so in preparation for that, they asked us if we would talk about the roadmap for working with a payer. There is a lot of different capabilities, varying capabilities in that group. But what we wanted to do was really check and see what was the temperature around understanding low value care and high value care, because it really, for us, the work that we've done with the independent ASCs in New York City and Long Island has been around identification of those that are what we would consider high value care. And so when we started the talk, you know, we really just started to talk about high value and low value. And I checked and asked some questions, and the participants were able to give us examples of low value care. So I felt really pleased that, you know, the understanding is you know, becoming greater, at least in New York. And one thing that we did was actually, because, you know, I'm a half glass full girl. So we talked about the actions that the ambulatory surgery centers could take around high value care, and then also the what high value care was. And so we handed out high value care dollars, because we said, you know, this is a lot about, if you have a bucket of money to spend and you're going to need to spend that healthcare dollar wisely, let's all talk about how, let's have a conversation about how should that dollar be spent. And so it was just really, it was a very successful discussion. And I just felt like the time is really ripe, I think, for having those conversations at the society level. And that will really help drive the conversations, you know, through the whole healthcare ecosystem. And then we talked about, you know, the healthcare ecosystem and how, you know, it's really about making sure that the patient and the member get the right care at the right time in the right setting. And I was just really pleased that, you know, the light bulbs are really going off in the group around how they participate in that healthcare ecosystem, and, you know, what each role is to make sure that we're keeping that patient at the center. So it was fabulous. And we had, as a result, one of the eye centers came up to me at the end, and we talked about, geez, you know, they do a lot of cataract surgery. Maybe we should talk about a drop the pre-op for cataract surgery in exchange for diabetic eye exams. And so they were thrilled with that idea. And so we have a follow-up now to see, you know, maybe we could, you know, start to finally put that great idea that we talked about a couple of years ago, Cliff and Mark and Adam, into place. So it was just, I feel like the timing is right out there. You know, I just feel like, I don't know if other folks are feeling that and seeing it, but I certainly did after last Friday.
Well, Carol, certainly in New York, but in other states as well, the sort of the water level of understanding is rising. It's not like you see blank faces every time you say low value care, high value care. So there are some lessons there, and it kind of helps us track the progress we've made in sort of diffusing into health policy literacy, as it were, these concepts. So thank you for that kind of, it is a very helpful update. Thank you very much, Carol. Jason Spangler, the last time we had this meeting, you were doing something else. You had a different job. Jason, give us a quick update on where you are and what's up with the low value care, Jason.
Great. Thanks so much, Cliff. Good to see everybody again. I think as many of you know, I used to be part of this task force as a supporting organization from Amgen. I left Amgen in July, and now I am the CEO of the Innovation and Value Initiative. And for people who don't know that organization, it's about 5 or 6 years old. It started out as a consulting project, and now over the past 2 to 3 years, it transformed into a nonprofit research organization that focuses on, how do we improve value assessment? So how do we improve methodology? How do we incorporate aspects of value that aren't part of standard cost effectiveness, transparent and patient-centered, and bring in health equity components? And so we're not focusing directly on low value care, but there is obviously a relationship between low value care and value assessment. And so we don't, and one thing to make clear, we don't do actual value assessments. We do some modeling, but we're actually just trying to improve the methodology around value assessment, and our research is focused on that. Cliff, one thing I just wanted to highlight is around the health equity. I think that's something that we need to keep top of mind as we think about low value care and the different populations that we're thinking about. And so we started a health equity initiative earlier this year, a 2-year initiative where we're going to focus on the components of health equity that are important to value assessment. You identify the data gaps around, not only the methods around data, but collection of data and how that relates to value assessment. We also want to come forth with kind of best practices or recommendations to value assessors and HTA organizations around that. And then, basically, we have all the stakeholders to come to a consensus about where we need to continue research in that area. So we're excited about this. I think it could have some impact on the low value care work. We have a steering committee. We're starting a fellowship on this. We're going to have a roundtable coming up, and hopefully some documentation, some best practices, recommendations, publications. Look for a publication probably shortly as well, just kind of case studies on this. And so we're excited about this. And I think there is some kind of synergies with some of the low value care work, or something at least we should consider as we move forward with, working on low value care. So thanks.
Jason, you took a big deep dive into this right away. Just ever so briefly, Jason, you mentioned equity.
Yeah.
Can you sort of, in a little nugget, explain potential upsides and downsides of trying to get after low value care insofar as equity implications? Just a brief thought on that?
Yeah, I think one of the things that would relate to this is how the quality of care that is applied to different types of populations. There's plenty of data around, minority populations not getting the right type of care, probably not getting the high value care that they need. Right. So, I think the inverse is true too. They're probably recommended. And I don't know if we've seen some of this. I think there is some literature around this, but I think we probably need to do more research around, are certain minority populations, are they getting low value care as well as not getting the high value care that they should be? So I think that's one area that we can definitely look at. I think the other area is just broader around care in general. There's structural racism within our healthcare system. I think there's pretty good evidence of that. And so I think just in general, addressing those things is going to relate directly to kind of the low value care that, shouldn't be given to patients, particularly patients in those populations.
Absolutely. That is something we've got to really track very carefully. In a moment, I'm going to go over to Denise, but I just want to make sure folks are seeing in the chat a superb comment by Jeff Levenshirtz out of Harvard insofar as what's going on with medical price inflation and why this should call even greater attention to low value care. And Carol Huffman points out as well that this is resonating throughout the system. So thanks very much. Fendrick notes the stat piece from IVI and the equity issue as well. So nice reference there. Denise, it is great to have you here from Washington Health Alliance. And we want to kind of turn over a few minutes to you to give us an update on several important issues. Denise, are you ready?
I am. Thank you, Cliff.
Thank you.
I'm going to share my screen. If that's okay.
Absolutely.
So, okay, you should see our acute low back pain care pathway.
We do, and it looks interesting.
Great. So we launched this project in February, and we have 31 organizations, multi-stakeholders, providers, health plans, and purchasers, so employers and union trusts as purchasers of healthcare, participating in this collaborative. Our focus on acute low back pain, and we started with this care pathway, which has seen many iterations over these past, no, but 9 months now. And I will, after I'm finished here, I'll drop a link so you can see the full pathway, because there's commentary to go with each number. But I'll just point out that the green boxes are where high value care takes place. And our primary focus has been on the timely triage. And then with, identifying any yellow flags that may exist, really what's been important is the supported self-management. Because typically, like about 90% of people experiencing acute low back pain can heal themselves with the right direction, education in terms of what exercises for them to do to prevent themselves from moving into a chronic phase. And we thought if we stayed focused on the acute, then we would have that downstream impact. Okay, so I'm going to go to next slide, and suddenly I lost that. So the whole purpose of this is for the people who are participating in the organizations to take action. And everyone signed an agreement when they said that they would participate in this collaborative to take action. And so we've been holding them to that. And we have 80% who continue to report to us on a monthly basis on the steps that they're taking. So here we have purchasers where they're educating their members on acute versus emergent low back pain. They've considered incentivizing for first point of care. They've some of them have contracted with point solutions to help with that. They're broadening their benefits to include comprehensive integrative pain management. The Washington Healthcare Authority participates in this collaborative, and along with the public population, the schools and state that they provide benefits for, they also run the Medicaid program. And so they've actually added chiropractic care and acupuncture for 2023. So that was a big move for them. Providers, they're looking at a system level of how they're treating their low back pain and reviewing our care pathway and using that to educate and make updates within their system, including EHR triggers. Reviewing the clinical decision aids, right? So used for assessment and triage. So again, that relates back to EHR. The stage plan to educate patients and providers. They're looking at how they're measuring for improved high value care, where low value care is taking place. We've had providers take a hard look within their organization at their data to see how they're doing, to create a baseline for themselves so that they know that they're being successful. And so that includes looking at number of calls to PCPs that result in emergency department or urgent care use, because we've seen quite a bit of low value care come out of patients starting with the PCP. Health plans, they're developing reporting measures. We've made it really clear to them to hold them accountable that not just the purchasers will be coming to them for reports, but the providers as well, because the providers are unable to see what happens outside of their system. And it's important to them to know, one, when their patients are leaving their system for care, and then the other, for them to be able to benchmark themselves against other providers in Washington. So the health plans are prepared to support in that manner. And then we're also looking at creating a forum to empower the PCP network to implement the care pathway. And that's a few. There's more actions being taken, but thought those would be good ones to share with you. And then, as was just mentioned about the importance of equity and keeping that in mind. So with all of this, we're looking at how we improve on equity, and also to make sure that actions we're taking aren't creating inequities. So we have had purchasers implement programs with a zero copay for 24-hour access to triage, and we're starting to see good results on that. And we'll receive updates next year on how that is looking. So that's another nice part is, I mean, the folks who are participating in this collaborative they're all in and willing to, have made a commitment to really track this and continue to provide updates to us. So then in the incorporation of race and social determinants of health data in MSK reporting in their dashboard. So where they're working with point solutions, they've been able to add that in as another point of measure, an area for them to be able to watch just at a click of a button on how they're doing. Providers have created educational materials in multiple languages. They're practicing shared decision-making and continuing to educate their population on that. One thing that's really come out of this is how large systems are challenged to get to all of their clinicians. They're really finding that they have to keep getting in front of them to educate them, even on the programs that they have going on within their system. So, and then we had one champion new legislature that would provide coverage for all for chiropractic care. And there was a recent study done out of Optum Labs that shows that chiropractors are relieving acute low back pain in 1 to 3 visits. So they're actually the least expensive, quickest return to health out of all the practitioners, at least based on Optum's recent research. Increased timely triage with trained clinicians. So there are some health systems who are able to do triage internally. That can also be a challenge for some of them too. They really do rely on, they're not able to always set up a place to channel the patient in specifically for, spine care. So that's where partnerships are required, and I think we're helping to break down those silos between providers so that we can do a better job of creating this equitable environment. And then health plans are working to expand their coverage for evidence-based alternative therapies. And then we had one deploy bilingual navigators. And so they focused on communities where English was second language. And what they found is that more providers wanted to become a part of the network because of the results that were taking place as a result of having these bilingual navigators work with their members. So we were really happy to hear that is being so successful. So I'll pause there for questions before I go into where inertia is.
Okay,
existing.
This is very helpful, and you've been hyper productive here. Got a couple questions. Let's go to Mark Fendrick first. Mark, what would you like to raise with Denise?
Thanks, Cliff. As we've talked about in the first 11 meetings, Cliff, discussing these issues is hard, but putting in programs that remove low value care is much, much harder. Denise, you make this sound easy, and all of us who've been doing this, you know, I'm part of this team and have been working with Beth and many of the members for quite some time. You made this sound amazingly straightforward and seamless. Would you mind, without bringing up too much trauma for you, raising some of the challenges that you have, since we know some of them were kind of unexpected, at least unexpected from stakeholders that we thought would be easier to deal with?
Sure. Yeah. Thanks, Mark. So challenges as basic as who's engaging from the organization changing. So, you know, one organization I think has had a change in staff. Probably we've had to like reacquaint like 3 different people to the project for a single organization. So that's been a little bit, you know, of a challenge for us. But I'd say like a bigger, broader challenge has actually been with the health plans and getting them to agree to take action, to say that they are contributors to the problem and they will come up with solutions. We have, I will say that Primera has been extremely proactive, which is really good because they have a large percentage. I think they have about 60% of the total population in Washington. So we've been really pleased with that. But trying to pull the others along has been a bit challenging. And the providers who could potentially, right, get hit in the pocket with this have been just all in, very, very interested in taking action. Internally, no surprise, most of them have challenges in terms of staffing and having the human resources to carry things out.
Absolutely. Denise, did you have other comments about barriers and hurdles and so forth?
I have, so I'll just show, we facilitated a discussion on inertia recently. So we're, you know, we're trying to drive to at least one thing that everyone can agree on that they're going to act on, right? So we can really move the needle in Washington. So so here we have, you know, purchasers, multiple competing priorities at one time, right? No surprise because they're, you know, usually have a slim staff for benefits. Anything that costs more money has to be vetted by union groups, so it can take them 2 to 3 years to implement what we're, you know, discussing right now, and other employers can just act on immediately. And then the time to implement benefit design change, which really relates back to oftentimes to having to work with union groups. The providers, as I mentioned, staffing resources, large organization entrenched in old ways, right? How do you get the education out there to the clinicians and bring them up to speed and break down those old habits, create new behaviors? No single source to measure and identify who is delivering high value care. So we're working on that piece. At least we have the health plans all in agreement that they will all be reporting on the same standards. So that's a plus. And then national health plans saying that it's very challenging for them to do things locally. And then that value-based contracts are in place, that they're doing their job. You know, the health plans are doing the work, but plan sponsors just aren't utilizing them.
Well, Denise, even though, you know, the inertia may cause discomfort, I mean, what you have here, you've got basically 8 items up there that apply for many of the folks that are on this call trying to make this kind of stuff happen. So if you're trying to be really pragmatic about the hurdles faced here, as you know, as Beth and others have mentioned, this is what they are. One quick follow-up question on the data. And again, the equity thing came up a few times. You said that you're getting race and SDOH data. Briefly, what are those data and where do you get them? Where do you get race data? Where do you get social determinants of health data? What data are you talking about?
So So we run a voluntary all payers claim database. Now, I will say that this project, this is funded by Arnold Ventures. We did not receive funding to manage the reporting for this project, to run the data. However, we do have the ability to apply the area deprivation index to our data. And some may know it as the neighborhood atlas, but that, that's out of Wisconsin. And so we will be reporting on all of our data next year using with ADI layer over that. So all HEDIS measures that we report out on and our total cost of care.
I'm so glad you mentioned, by the way, thanks for tossing HEDIS. The ADI, I happen to be familiar with it. If I'm not mistaken, it's got like 17 variables in it, right?
It does.
Right.
It pulls in census data. And
Yeah.
it does. It has 17
And
measures.
it's out of the University of Wisconsin. We have found that to be pretty useful. There are other alternatives and so forth, but that's a pretty good source. And it is the full data set or subsets of the data are pretty good proxies for disparities. Not perfect, of course, but I'm so glad you mentioned that. And it's imperfect, but it's pretty good. And people maybe can kind of consult with you to figure out how you've used that and sort of the upsides and downsides. So thank you very much for that. Any further questions for Denise's excellent presentation here? I'm just looking for any hands raised.
And I'll stop sharing.
Okay, thank you. I want to put Mike Chernow on the spot. Mike, tell us briefly where you are with Growl. For those who don't know what it is, just give us a quick thumbnail on that because it's a nice sort of bookmark for us. Mike?
Yeah, so I'm not going to go through what Growl stands for because it's just too cutesy for such a august audience. But the gist of the idea was to try and figure out how to engage employers to engage carriers to work on this particular problem. And in Denise's slide where she spoke about the inertia, the one that she just had up, that she's no longer sharing, she talked about the plans and the providers. I think one of the key groups there ends up being the employers. And in that ecosystem, you have the benefit consultants. And the idea behind Growl, and let me say before I go into it, I know because I see who's in this group that there are really advanced carrier organizations that in fact are doing a lot to reduce low value care. Much of that flows through the process of prior auth, which we haven't really talked about much here. But what you see repeatedly, and you heard that from Beth today and a bunch of other folks, is really getting the employers on board to bring together the payment systems around who's paying for this low value care is what Growl was about. So the basic idea was right now, the financial bag that is being held by the delivery of low value care is largely employers, a little bit the patients who have to pay out-of-pocket costs for low-value care. In many other settings, employers wouldn't buy inputs, wouldn't buy things that provided no value. In healthcare, they do. And the plans, legitimately, I think, are doing a lot and have a lot of intentions to reduce that low-value care. And there's a lot of pushback. There's a lot of pushback on prior auth. The one thing that's nice about some of this work, and again, we had Carol speaking from Emblem and Beth speaking from BHI, Denise was talking from Washington, a bunch of other folks. There actually seems to be an engagement on the provider side, and we've seemed to have a hard time bringing together the purchaser infrastructure to change who's at financial risk for the delivery of these low value care. And that's where Growl has kind of been moving, but I'm not sure if Jeff Levin-Shirts is on now and he wants to talk about it, because Jeff has been a great ally at Willis Towers Watson and how to do this. Jeff, if you're there, raise your hand. You may.
I know Jeff is here. Jeff, do you have a comment briefly to make?
He may have stepped out.
No, I'm here. I was eating some lunch, so I didn't want to show my face. Yeah, I mean, I think that you stated it well. That as I put in the chat earlier, employers are much more focused on total costs right now, just because 2023 total costs, whether they're premiums or self-insured, are going to go up a lot more than people have been accustomed to for the last 10 years. And given that a lot of contracts are 3-year contracts, I think that this pretty much guarantees we're going to have that issue going on for at least 3 years. So I think employers are more focused on it. The challenge really, I mean, there is a data challenge, and I mean, that I've been sort of pushing some clients to actually do some data analysis, on this, including potentially using the Millman tool. And honestly, it sort of seems like the process of making that happen seems to exceed the tenure of the people involved in working on it. So that's a bit of a challenge. But I think this is a fertile time. And one of the things we need to show, though, is that there is enough money here. I also think that in some instances, like for instance, with things like vitamin D, and some of the health plans have actually stopped paying for vitamin D testing without an appropriate diagnosis, something that I applaud. I think that in some instances, what we're going to end up doing is we're not going to deny a whole lot of things, but we're going to change practice patterns because labs just simply won't accept test requests unless people put better reasons. Now, some doctors will, of course, simply check the box regardless, but still, it's just like prior authorization for radiology and stuff. Most of it is changing people's behavior more than denying things that are ordered.
Yeah. Well,
Yeah,
Jeff,
so let me
thanks
just
very
say,
much.
Cliff, I know you're going to go to Will. Cliff, I know you're going to go to Will. I just want to finish up because I don't want to take any of Will's time. I just say this. I know we have Ron to hear from PBGH. Cheryl spoke a little bit ago from MBGH. I just want to encourage any employer on the call, on the Zoom, to get in touch with Jeff. I really think they're doing outstanding stuff. And any carrier, we've been trying to build this coalition between employers and EBCs, which seem to have the ears of the employers, and the carriers, many of whom are committed to the goals that are on the line. I know many of you. And so I just encourage them, either through us or not through us, to reach out to each other to kind of move this forward. And getting people who seem to agree in substance to agree in action has actually been harder than an academic can make accomplished. But luckily, I'm gonna do a fun thing here. Luckily, the speaker coming up next is both an implementer and an academic, and has a tremendous perspective. So Cliff, I'll let you do the real introduction, but I am thrilled to hear from Will. So I will go back off video and mute.
Well, that's pretty good right there, Mike. Let's go to Will Schrank. Will, you've had quite an odyssey in the last several years, and for that reason, we thought you could provide a multi-view or multiverse perspective. Will Schrank, we're very interested in hearing your views on addressing low-value care from a health plan perspective. Over to you, Will. You may be on mute still, Will.
I am. Pardon me. Sorry about that. I'm out of practice. Can you hear me now?
We can, yes.
And I'm trying to put this up as a view. Can you see the slides?
Yes, we can see the slides.
All right.
It's not in slide view yet, but looks like it's on the way.
Well,
there it is.
This is an interesting, I think that this last part of the conversation has been really interesting in that it's important, I think, to draw the distinction between employer sponsored insurance products, commercial products, and government sponsored products. And the role and the engagement level of the payer when they either are or are not taking risk. And as someone who's worked for the last 3.5 years in a predominantly government-sponsored plan, largely in the MA space, I don't think there could have been more emphasis on reducing low-value care. And this sort of distinction that it's hard for employers to get the attention of payers in commercial employer-sponsored plans is it's a little disturbing. I don't know if disturbing is right. It's a little surprising because unless those plans are not spending a ton of time, unless those plans don't have government business, it means they're turning a lot of things off for your members, your employees, that they do for their Medicare Advantage, Medicaid members. So, I mean, I'm coming from a bit of a different perspective, but I'm disappointed and frustrated to hear those reports. I'll just start by saying that it is awesome to have a chance to join you guys today. I have been following and admiring Mike and Mark for a good 2 decades now, and I think your work has really informed and guided my work, my research, my work in the private sector, my work in the government sector. So it's just awesome to see that you're continuing to lead and continuing to evolve in terms of how you have an impact. And I'm honored to have a chance to join you all here today. And I also will start by saying that, you know, I've sort of used a little bit of different nomenclature than you have. I've been thinking about this for some time, some of these same topics for some time, but I've used nomenclature that's maybe a little more broad, and the terminology has been waste. We can talk a little bit about that and see where that poses a problem with respect to how, you know, some plans are thinking about these issues and the extent to which we need to be really clear about how we talk about them so that we know we're talking the same language and we're focused on the same outcomes. So my focus on waste started, started in earnest when I was at UPMC maybe 5 years ago. And to some extent, it was driven by this notion that there was this huge amount of emphasis in around 2011, 2012. Don Berwick and Andy Hackbarth wrote this great paper about quantifying the amount of waste in the healthcare system. It was just as the Innovation Center was just being stood up. I happened to be working there just as it stood up. And there was this sense that at that point, by changing payment models at scale, by really reforming the way we think about payment, that some of these opportunities around waste would sort of just naturally be addressed in a much more efficient and focused way. But 10 years later, these issues remain. And the problem of affordability in healthcare for patients, for Medicare beneficiaries, for society in general, have not diminished. And I really wanted to kind of get a sense of where we are in terms of understanding the evidence across the waterfront of interventions that can reduce waste. So sought to essentially redo Don's awesome study that he published in JAMA in 2011, and use the same categories that he used to quantify waste. Failures of care delivery, you know, is sort of the right care being delivered to the right patient and done effectively. Is failures of care coordination, more focused on patients with multiple comorbidities, patients who are transitioning from different sites, the ability to manage those patients across conditions, across settings. Overtreatment, low value care, and we'll talk about that in just a second. Issues around pricing failure. Are we just paying too much for something that we should pay less for? In the words of Uwe Reinhardt, is it just the price is stupid? The extent to which fraud and abuse is a contributor, and just this concept. I'm sorry, somebody have a question? No. And this concept of administrative complexity. Just the time spent doing activities that provide no meaningful value for a patient. And I wanted to bring this slide up just because when talking about low value care, some people have a more constrained view and think really of that third column here, that sort of over treatment, providing care that's not appropriate, that isn't evidence-based, that's potentially harmful, but that, and if not potentially harmful, unnecessarily expensive. And I think it's important to think about this notion that from a health plan perspective, we're kind of looking across these categories. And the way in which we talk about low value care versus these broader definitions of waste can be, I think, a source of miscommunication. So that may be something we could talk about later in this discussion. But here's what we found. First of all, in terms of, we did a very broad review of government documents, a systematic review of the literature to try to understand the sources of waste and the extent to which the cost of waste in those 6 categories. And many of you have seen this. This got a lot of attention when it was first published in JAMA in 19. And these numbers are offered as ranges because when synthesizing the evidence, there were not precise estimates that came out of that synthesis. It was more ranges of opportunity. And it's on the order of $750 billion to nearly $1 trillion a year. So we waste more in healthcare than we spend on pretty much anything else in our economy, more than we spend on defense, more than we spend on education. And when you look at the categories, I think it's pretty instructive also that while these are all rough estimates, and I would not put a lot of weight behind any of the point estimates here, I think directionally it's useful. And administrative complexity represents really, really a massive source of waste in our healthcare system. It's also interesting to note that when you sort of combine failures of care delivery, failures of care coordination, overtreatment, low value care, really the care delivery components, features of this review, when you add those up, that represents just an extraordinary opportunity to deliver care better. And through better care delivery and more targeted, appropriate care for patients, reducing total cost. And it's essential to recognize that, we're not seeing although this was not set up as a direct comparison to the study that had been done a decade prior, these numbers are on the same, in this sort of the same category or the same range as we saw when Don Berwick wrote his really landmark study a decade earlier. So we also looked at the evidence to date of improvement in waste in each of those categories. We looked in each of those categories for evidence of interventions that can reduce waste, and did our best to estimate what would happen of those that are successful and where waste was demonstrated to be reduced, what the expectations could be if they were scaled. If those interventions were scaled nationally, what the savings could be. And I'm sure your knee-jerk reaction will be, these definitely should be taken with a grain of salt in terms of direction, or in terms of the specific numbers. The ranges are huge, and this presupposes tons of things that we really can't in terms of our ability as a health system to scale successful interventions. But again, I think useful directionally, and in the areas of care delivery, failure of care delivery, failure of care coordination, and overtreatment, low value care, you put those all together, there's a meaningful amount of savings there if we were just to scale interventions that we've found to work. And it's interesting, and I think really instructive to note that virtually all of those studied interventions where there was quantification of reduction in total cost of care, quantification of improvement in outcomes, and reduction in cost came from value-based settings. So it really sort of speaks to this notion that the places that we're seeing momentum, the places we're seeing change, is in the value-based care space. And it's obvious to say, but it's really important to note that one of the reasons these changes are hard is that one person's waste is another person's profit. And, you know, it's the prior auth is a perfect example. It's one that we talk about all the time. Payers leverage prior auth in order to reduce waste, in order to reduce low value care and reduce unnecessary care. Providers, and it reduces their waste. Providers experience waste because they have to do a lot of administrative things in order to satisfy those prior auth requirements, even when the care is, you know, indicated and appropriate. And as a result, we're seeing, you know, more and more effort from providers to push back on prior authorization requirements, even in the setting of clear evidence that prior authorization is an essential intervention to reduce waste and unnecessary spending. So we spent a little time thinking about, you know, some of the topics that have come up earlier in this conversation of, well, you know, what do you do about it? What are the interventions look like? And we're thinking about it in terms of the categories of what do you need and what works. We clearly need evidence to show that something is low value and should be de-adopted, should be turned off. We should stop doing it in patients where the value has not been proven. It helps to have eminence. It helps to have professional societies, you know, sort of leading influencers and experts in fields to advocate for de-adoption. But ultimately, we argue that it's the economics, and it's the ability to change formularies, the ability to change coverage policy that really makes a difference. We looked at a couple specific case studies. Somebody talked about vitamin D screening earlier in this conversation, where there's clearly no evidence to suggest that population level vitamin D screening is indicated. It was added as a choosing wisely indicator for low value care. And with that level of scrutiny and visibility that choosing wisely brought, no meaningful change. But I think this is definitely an underestimate, but in Canada, on a given day, the Canadian government stopped paying for vitamin D screening without specific indications, and the reductions were massive. You know, we're essentially, it was pretty close to stopping. And I'll tell you my own personal experience with this. That was, I think, really instructive is when I was at UPMC, we spent some time trying to think about how to address waste in pharmacy spend. And in a integrated delivery and finance system where the payer and the provider, you know, sort of are aligned financially, and where savings are shared by both the payer and the provider, reducing unnecessary pharmacy spend is a really striking opportunity, especially because it's not revenue for the providers. So it's a way that it's not as directly contraindicated for the business model of the provider. And we encouraged our providers and risk-bearing in sort of risk primary care practices to take, we created risk arrangements that included pharmacy, and we encouraged them to target specific opportunities where our data showed that there was meaningful waste. One example was in patients with COPD, there was considerable amount of branded drug use when there were new and equally effective generic inhaler medications, long-acting inhaler medications that could be substituted. So we sort of at a high level as a payer and a provider encouraged our providers to change behavior. It was incredibly unsuccessful. We got, 1%. We created an academic detailing program to go out and meet directly with providers and educate them about the opportunity. Again, this is free money for them if they can make that switch, because they will share the savings and they don't make any revenue from prescribing a more expensive drug. almost no benefit from academic detailing, and from bringing actually experts from within the system out to talk to the primary care providers. We had the flexibility in our Medicaid program to make a formulary switch that essentially made it very, very hard to step through and get to the brand. And within a month, 98% reduction in initiation of those branded long-acting inhaled COPD medications. In our other products, where we were unable at that time to make a formulary change, the behavior did not change meaningfully. It really, really speaks to how important sort of the economics and those policy changes are in guiding, changing, in instructing, and ultimately in altering behavior for providers. So this is probably the worst slide you'll see this year. I apologize in advance. And this is what happens when somebody who's worked in like big companies and has had teams suddenly becomes unemployed and has to make slides for himself. It doesn't go very well. So I apologize in advance. But this is a study that we did with Aaron Schwartz, who may be on the call. I know he's talking later. And like many of you, we've been researching and trying to understand what are the features of, or what are the kinds of things that actually impact low value care. And we sought to better understand. There've been a handful of studies looking at provider characteristics, patient characteristics, but there hadn't been a really thoughtful study looking at insurance design and how that impacts low value care. This was the reason I don't have a good slide on this. Was just published a couple of weeks ago in JAMA Health Forum. And we compared low value care across 26 measures. These are the measures that Aaron has been using on a number of very high visibility studies. I think he probably developed them with you, Mike Chernow, when he was working with you at Harvard. And it's large, these are sort of the widely accepted measures of low value care, and compared performance in traditional Medicare using the 5% sample, and in Medicare Advantage using data from one large insurance company. And I can't tell you who it is, but it might rhyme with Bumana. And in general, overall, this I think shouldn't come as a surprise to anybody. The rates of low value care in Medicare Advantage, a little over 9% lower as compared to traditional Medicare. It's notable that in each of the 6 categories that we looked at, those at least directionality and from a statistical significance point that those differences held. Medicare Advantage performed better than traditional Medicare in each of the sort of the clinical areas that we focused on: cancer screening, diagnostic preventive testing, preoperative testing, imaging, cardiovascular testing, procedures, and there was another category as well. We also looked at some specific features of the insurance design, and found that consistently in HMO products, there was considerably less low value care as compared to PPO products. And what's really different about HMO products at Bumana is that first, you're required to have a primary care doc who is accountable. And there's also a bunch of more stringent limitations in terms of how the network is designed and where referrals are authorized. So we saw a meaningful difference. But to me, the thing that was most interesting and most informative was a comparison within Humana's membership of those in risk-bearing, who are cared for by providers in risk-bearing relationships, as compared to those cared for by providers paid fee-for-service. Within Humana, meaningful reductions in those in value-based relationships, in particular when providers are taking two-sided risk. So meaningful both up and downside risk, much less benefit in members that were cared for by providers taking just upside risk. And I think this sort of speaks to this our intuition, but another piece of evidence around how this more rapid move to value-based care in terms of how we pay our providers impacts so many features of the kinds of care that patients get, and really sort of emphasizes the ability to leverage better payment, more aligned payment between payer and provider with the goal of reducing low-value care. So I just took, for the purposes of sort of setting up a conversation, took the opportunity to kind of lay out, I think these are probably the 6 areas I spent the most time thinking, working over the last 10 years on this topic in a variety of different settings. And just for the purposes of the conversation, I'll lay them out quickly. One is around, there's a lot that we can do to reduce administrative complexity. And there is a huge amount that payers are, I think without exception, the payers are trying to do to automate, to make more facile the pre-authorization utilization management process, to make it seamless, to make it as electronically sort of in real time as possible. That's I think going to continue to be a real focus for health plans. Providers deeply appreciate it when progress is made there, and can be just off the top a waste reduction. As we continually improve our data interoperability so that there's better opportunity for teams to manage patients across different care settings, and we get increasingly better evidence. As I think every health plan and any risk-bearing provider is thinking about how to improve their care coordination. I am hopeful that with better data interoperability and better evidence about the interventions that work, that we can foster better care coordination and reduce waste. I am speaking to the world's experts here about how to engage patients better in the process, and our ability to create incentives that are nuanced and targeted for patients that are aligned with waste reduction through benefit design is critical. And I think I don't think anyone has done more to advocate for that than the folks who organized this gathering. I believe that provider incentive alignment is at the core of our ability to reduce waste, and will continue in whatever job it is I ultimately take to be a full-throated supporter of value-based care. You're seeing more and more focus around care setting, and plans. Providers are doing, sort of making meaningful investments, whether it's more care in an ambulatory setting that used to be in a hospital setting, I think, but more interestingly, more telecare, and me personally, most importantly, more care in the home that can drive better care, better experiences, and lower cost. And then pricing policy has been top of mind, really across this administration, and sort of central in part in some of the Inflation Reduction Act policy that was recently passed around prescription drug pricing, opportunities around biosimilars. I think there are huge opportunities across the board to rethink pricing, and the opportunity to move more towards transparency, I think, will only help. So maybe I'll end there and just say that I'm really optimistic. While that, our repeat study 10 years after the Berwick study didn't show a huge amount of change, I think the market is moving in a lot of really interesting and important ways to try to address each of the features of waste. And I think we're seeing these themes of innovation, these themes of improvement that could spell, real meaningful reduction in cost improvement in care, improvement in outcomes for our patients, our members, all Americans. And I think there's lots of reasons to be optimistic that we're heading in the right direction.
Well, Will, thank you very much. And we do, and you've right on the button, saving some time for Q&A here. By the way, since you did mention Aaron Schwartz, he's going to be up a little bit later on this afternoon. So we're going to ask him to reflect on some of these issues as well as some other newer stuff in the pipeline. As questions are going to come up, we're going to take Cheryl in just a second. One quick one for you though, Will, is that both the direction and the magnitude of the data comparisons that you're presenting seem to be irrefutable. Are you still getting any pushback or doubts from anywhere in the field, from industry or providers, the professions, that you don't know what you're talking about, or you're really undermining quality of care? Or is this pretty much widely accepted that these are true effects in both the direction and the magnitude?
True effects in terms
these differences, let's say between Medicare fee-for-service and Medicare Advantage, all the comparisons you've shown, just about all of them are pointing in the same direction.
Well, I mean, I don't think there is a lot of pushback on the notion that value-based care it can and will be an important tool to reduce cost and spending and improve care and improve outcomes. I do think that is not the storyline that I hear most when I'm talking to providers today.
What are you
when I talk to providers today, or when I had a job, and that's what part of my job was, providers talked about in the setting of the pandemic, they got really beaten up and they're struggling and they're hurting, and forcing them to move to a new care delivery model that will require both an investment and a meaningful financial investment and resources, but also a meaningful transformation in how they deliver care, is overwhelming to them. And I got to say, I understand that. I understand where they're coming from. These, providers have been doing God's work for the last couple of years, bending over backwards to figure out how to make their systems sort of flex to the needs of a very, very different landscape, a different environment. And suddenly saying, and you know what, your whole business model, the way you've been paid for the last 20, 30, 40 years, we're going to change it next year. And you better figure this out, I think is overwhelming. So I would say that while there is not a lot of refutation of the sort of notion that value-based care can put us on a path to delivering better care and lower cost and reducing low value care, I do think that the process, the path, the timing, the way in which we support providers to get there is paramount. And if we can lose this opportunity where the evidence is really compelling by pushing too hard at a time where they're really, really stressed and losing a ton of money, and have really focused on the good of the populations they serve over the last couple of years to their own detriment.
Yeah, it's just interesting. One wonders whether if the pandemic weren't the reason to resist change, something else might be, because this isn't the first time they're hearing the messages, although your work really kind of nails it, I would think. So in that case, let's go over to Cheryl Larson. Cheryl, what do you have for Will?
Hey, Will, that was really, really outstanding. I very much enjoyed it. I had other questions, but as you made your final comments, the question changed. So if providers have been beaten up and asking them to transform healthcare is hard right now, and there's so many stakeholders we have to look at to transform healthcare, should it fall back on the health plans and the PBMs and the benefits consultants to work on the things like not making prior authorization so difficult? Or I believe that intermediaries in the system have a lot of wasteful practice that increase employer costs, and that is part of the provider community as well. But if we've had new and somewhat misguided legislation for employers over the last year or so, requiring them to do some things like, hey, how much are you paying your PBM, your health plan, your benefits consultant, your broker, your TPA, but the employer can't even see what the amount is. I know that's on the fully insured side, but what can employers do to support the efforts to start with the top one or two things? You know, if we look at low value care, we're always, you know, Mark always says we're not adding to the list until we get these other things right. What are the top two things you would recommend?
Yeah, well, I'm not sure I have a satisfying answer to that really good question, Cheryl, and I appreciate the way you frame that. I think you're asking sort of the real world hard questions about where do we start and where do we emphasize. To me, I think if a key goal, and I think one of the key goals has to be to encourage a movement towards value-based care faster. I am concerned today in the short term of expecting hospitals and health systems to change their practices in a sort of overnight. I do think the place that and this is the evidence is really, really clear. A lot of it's come out of Mike's shop, that the place that we're seeing the greatest benefits in reducing waste, delivering better care, reducing unnecessary cost in value-based arrangements is where the primary care providers take the risk. Primary care focus, risk-bearing arrangements. I think you're going to have a hard time getting health systems to, move quickly. I think if I was an employer, I'd be working really hard to change the way I relate to and contract with primary care. I think you can rely on and you can partner more deeply with primary care docs who don't have the same level of fixed cost investment, don't have sort of these entrenched business models that are focused on utilization, and that really can focus on doing what's right for the patient in front of them and thinking about how to care for them between visits, which is not something that most health systems are oriented around. So I think that's where I would push hardest, is around payment models, partnerships, contracting with primary care docs.
Thanks, Will. Cheryl, you okay with that response? What do you think? You're on mute. I think you might still be on mute, Cheryl.
Sorry, I'm okay with it. I agree with it, and it was thoughtful. Thank you, Will.
That's the nicest thing I've heard in a long time.
And thank you, Cheryl, for raising the issue. Let's go over to Scott Weingarten. Scott, what do you have?
Yeah, Will.
Hello, Scott.
Hey, Will, fantastic presentation. Extremely well done. I'm going to extend Cheryl's question just a bit. Let's say tomorrow you become CEO of a health system, which has a significant percentage, a large percentage of patients in value-based care, reimbursement, and an increasing percentage, and a large primary care base. And the board gives you a mandate to eliminate low value care. So you have some advantages starting out. What would be, and you commented on this in response to Cheryl's question, but let's say, what are the first few things you might do in order to, what would your highest priorities be?
Yeah, I mean, I think I would start, I would start with the things that would make my providers happiest. Because I think that's where you create the greatest amount of friction in an organization, is when you encourage them to do something that's meaningfully different and make their lives a lot worse. The place that we can make lives better for those delivering care is around a lot of this administrative complexity stuff. I'm amazed when I go out and it was true for me as a practicing physician. That was, I think, 600 years ago. But for those that are caring for patients today, the way in which their biggest complaints are around how they spend their time, the ways in which they're, how they have to allocate their time to whether it's interacting with, it's truly administrative complexity and pure waste. And I think there are, a modest amount of investment that you can make around information technology infrastructure, differing partnerships with payers who are all committed to at differing levels, but all, I think, I genuinely believe, all committed to making it easier for providers. In a setting where we have, I think more clarity on data standards, where it's going to be easier over in the next year to two to be able to sort of satisfy this goal of simplification. I think that's the thing I'd run at really, really hard as a hospital administrator. I will say, Scott, that it's very unlikely that's my next job.
Okay. Even though that's unlikely, your next job, great response. Thank you.
Thank you.
And thank you, Scott, for the tough question. We like it. Let's go to Mark, and then we'll go flip it back over to Mohammed after Mark. Mark?
Scott and Will, that's amazing. Will, thank you very much. I would give you a standing ovation, but I'm sitting in my seat and you can't see me anyway. Just a couple reflections, because I've been waiting for 6 years for this presentation. So, a couple points. Having seen patients this morning, the idea of making our colleagues in primary care lives better, clearly the idea of taking work off their plate, but certainly paying them more. And paying them more for doing less has really been the focus of what Mike has largely been spearheading about these contracts that you're talking about, that not only reward people for doing what they should be doing, but actually reward them for doing less of the things that they shouldn't. And we've had some successes largely through this task force, and the Federal Employee Health Plan. Others have some things in place to actually move that forward. It's important to point out, though, that is, as much as your kind words about benefit design, where we are, Will, in the task force, and I strongly believe if you look down the list that we put together, that Aaron's extrapolated in Medicare around low value care, very, 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 very few of these things are demand side or patient driven. Almost all of them are supply side or provider driven. And one of the things that is important to point out is that there have been a number of things that we've tried to do, and to benchmark, to remind, to educate. But as you showed the example from Alberta and vitamin D, and something that's been our top priority in the task force, even though it's not enough money for Chernu and Beth Bortz's board and others, is that if you don't pay for things, people don't do them anymore. And I think that's something that's a really, really good example of that. So I am hopeful that your comments will be able to move us forward. But I do, tying back to my friend Cheryl, is when the payers ultimately have the courage to lean on all the stakeholders between them and the clinicians to basically say you're going to share a significant percentage of the dollars saved on no value care with the providers who don't order them, I think we'll have success. And one of the reasons why we've gone from low value care to no value care is we want to focus on those services that hopefully are going to be easy to reduce, and there's not a lot of revenue made by clinicians doing them. And that's why you should know vitamin D was always my #1 low value service, because thankfully no one on the clinical side makes money from doing an unnecessary lab test. And as I put in the chat before you came on, I think that I've told everyone I've met in 49 states, if they diagnose a case of rickets, given that I'm no longer allowing ordering a vitamin D test and payment thereof, they could call me. They could call me 24/7. So thank you, sir, so much.
Hey, just to build on one thing you said about sort of the primary care providers and that challenge around how they interact with specialists. It was interesting to note that the reductions in low value care in value-based arrangements and in HMOs as compared to PPO arrangements, so value-based primary care docs, or HMO versus PPO, was not in what the services delivered by the primary care provider. It was specialty ordered procedures. So it's engaging the primary care doc differently may not have as huge an impact on sort of how their own what they're prescribing in terms of their own services. It's more around how they interact with specialists, when they call specialists, how they select specialists, how they communicate with specialists, how they work together to manage patients across the continuum of care. And I think speaks to sort of the comment that you were just making.
Yeah, if I
Thanks,
may,
Will.
Cliff, one last thing, to loop back, Scott Weingarten, who his work has kind of set the stage for us in terms of tying into Will's #1 priority of making our lives in primary care better. So first is Beth Bortz's initiative around no value care in the Starfield Summit is hopefully going to put together a much more concise list of services that we are going to agree, primary care professional societies across the country, including those represented by Karen Johnson on the phone and the American Board of Internal Medicine, et cetera. So that is really, really exciting to think that we may actually have a longer list, Cheryl, that we might be able to do so. But to Scott's point, the idea that these alerts can be put in an Epic or other electronic medical record to remind us that either due to culture or laziness or just because we have nothing else to do in primary care, that we could order that upper endoscopy in a patient with uncomplicated GERD, or the long list that we have talked about, Will, at this meeting many times, is these alerts actually do work.
Yep.
And and Scott kind of set the stage for us to do that, one for high value care, but we're now seeing more and more that alerting us that we shouldn't be doing things, and the evidence is telling us that we probably are at best not providing clinical benefit and potentially harming these individuals, and reminding that this is not low value care or waste, this is harm reduction and equity enhancing is really, Will, where we are at our 12th meeting, kind of moving forward and bringing together these larger themes to tie together the importance of getting things that, really could provide a lot of funds for us to cover and pay more money for the services that are underutilized, which, since you didn't hear me say this, the reason why I became a low value care guy was exactly to rob low value care Peter to pay high value care Paul. So thank you.
I would stand up and give you a round of applause, except that would require you all to look at my midsection, which I don't think anybody wants to see. But I could not agree more with anything you just said. That was totally spot on.
Thank you both. For our last question, let's go back to Mohammed. Mohammed, what would you like to put on the table?
Thanks, Cliff. Fantastic talk, Will. Just to pick up on your point about administrative simplicity and automation. I think one of the areas that we're particularly focused on is looking at how prior auth and perhaps even prepay can be looked at for reducing low value and no value care. But one of the challenges has always been that you want to do this while trying to avoid friction, provider friction for high value care, as Mark Fendrick was talking about. I can't tell you how many times I've had situations come up as a cardiologist where I was implanting a biventricular ICD for a patient for class 1 indications where there's great data this would benefit the patient, only to come up to a rules-based system that denied it. And then I have to go talk to the prior auth folks to try to get it approved. And I think this is where we try to, get the power of machine learning to go beyond simply rules-based approaches, and, want to, get your thoughts on clinical nuance. So the idea of actually looking at the patient as a whole in terms of the context of why they're getting this procedure, why it's being proposed for the patient, and, the setting, and identifying that as perhaps a way of coming up with a more nuanced approach of identifying low value, no value care, while avoiding provider friction. I think one of the big challenges is that every time something gets denied, you're going to have angry provider on the other line calling and asking why it was denied.
Real briefly on that, Brill?
Yeah. So I'd say I'm not sure if I would focus on sort of the clinical nuance feature of that. I would just focus on the fact that for the most part, there are guidelines, and I think they're generally appropriate for the overwhelming majority of patients. And if we had access to data in clinical, and sort of not just claims, but in clinical if we had easy electronic access to clinical data as well as claims data, and there were good rule-based engines to distill and interpret that data, so much of this just unnecessary, those phone calls, the concern that the patient has, the fear that the patient's family has, the frustration that the doctor feels could be eliminated. I just really think that like in the short term, the answer is we have to. There is no way that healthcare today should be relying on people figuring out how to get a record and fax it. Like it's all on computers and it's all in databases, and we have to figure out ways. And if health at scale could do that, that would be incredible. But the more we can create automated pre-authorization processes, just make it really easy for people to get the thing that's appropriate for them, I think that would massively improve the lives of both the provider and the patient.
Yep. Well, there you have it. Mohammed, thanks for raising the issue, and you got a nice kind of reflection back at you for some next steps. Will Schrank, it's been too long until we had a chance to meet with you, but let's not make it so long next time.
Deal.
You really nailed it for us today, and I think also your remarks reflect very nicely on a lot of the work that's ongoing, and you provided some feedback in the form of data, reassurance, and good suggestions about how we may as a group go forward. So thank you very much, Will. We will stay in touch. Take care.
Thank you. A pleasure.
You got it. Okay, next up, talking about important issues here, we got to just dive into Braidwood and Becerra here, and Katie Keith here is the one to take the leadership on this. Katie, I'm a little nervous to hear what you got to say because I'm concerned about where this could go in our current environment. So lay it on us, Katie Keith. What do we need to know?
Hi there. Thank you for having me. Good afternoon, everyone. I feel like I've had the good fortune of presenting to you all before, and I'm only here with bad news. Not bad news, but news you should be aware of at least at this point. So hopefully those slides are showing up for everyone.
Yes, they
proceed
are.
like they are. Okay, great. So I'm going to breeze through some of this because I know this group is quite sophisticated and knows all about this stuff, but I do want to get to sort of the implications. Cliff sort of said Braidwood, right? This was a recent court decision we saw out of a federal district court in Texas by a judge we all know and love at this point. And perhaps I've presented to many of you on this before. For those who have heard me give this talk, I apologize. I'll try to punch it up so that's not a full-on repeat. But at a high level, I think many folks are familiar with this provision of the Affordable Care Act. It is one of the most well-recognized, most popular provisions of the ACA. It's also one of those provisions that's been around the longest. Many of the law's provisions took 4 years to go into effect. This is one of those that went into effect 6 months after the law was enacted. So you've had preventive services without cost sharing in place since September 23rd, 2010. It is one of the things that makes me personally more frustrated that it's been in place for 12 years. And yet sort of here we are with a significant number of the services, at risk from a court decision. So I don't want to spend too much time on this. Excuse me, but it is worth sort of understanding how the provision of the law is structured. And so you all know this. It comes from Section 2713 of the Public Health Service Act. And the law says insurers and group health plans, so insurers and plans have to cover B, without cost sharing, specified list of services. Congress looked to the experts to inform what it wanted all these private commercial plans to cover. And so look to 4 different categories of coverage. The first is, services recommended by the U.S. Preventive Services Task Force with an A or B rating you can get. Immunizations covered by ACIP. I always screw up that acronym. It's on the slide. And then preventive services for kids. So all the way from infants up to teenagers that are recommended by HRSA. And then women's preventive services also recommended by HRSA. So you've got 3 entities there, 4 types of recommendations. You all know there's been a ton of litigation historically over the women's preventive services guidelines, which is where we get the contraceptive mandate. That's been up to the Supreme Court, I think 3 or 4 times at this point. Now, though, in this Braidwood case, we're seeing this entire provision being litigated. So what we're seeing is the challenge is really getting broadened, not just from contraceptive mandate, but for the entire preventive services mandate. The other shift in why this case is so much more significant, in my opinion, is because a lot of the contraceptive mandate litigation we saw was over the regulations to implement the law. Here, the plaintiffs are jumping over the regulations and going straight to the statute and making constitutional claims. That is important because if you have a constitutional challenge that succeeds, you need Congress to step in and fix a constitutional defect. And so this is really my point there, is getting to the heart of the provision. The last thing I'll say about this part of the law is it applies in one of the most broad ways, right? I think folks think Affordable Care Act, they think or Obamacare, and they think narrow individual market. That's not the case here, of course. This applies to virtually every commercial plan, any plan except grandfathered plans, which, there's still some of those out there, but in general, most people, including in the self-funded market. There's a terrific HHS ASPE report from earlier this year showing about 150 million Americans benefited from this provision in 2020 alone. You add that, culminating effects back from 2010, and it's just a huge, huge provision. Again, I won't go into a lot of detail here, but there's more than 100 preventive services on this list based on those recommendations from those 4 categories and 3 entities. And that same ASPE report that I just mentioned shows that this provision has been overwhelmingly successful. I think Mark and some of the champions of this provision know this and had this vision in mind when they helped put this into the law, but we have seen documented increases in cancer screenings and vaccinations and contraceptive access. We are catching and treating diseases earlier, and we are narrowing racial and ethnic health disparities in access to prevention. So it's overwhelmingly been successful. But I do want to emphasize, I think there's a whole lot of services on this list. Folks go to contraceptives, or you might have seen a lot of the press about this case focused on PrEP, pre-exposure prophylaxis, but it's any type of cancer screening, tobacco cessation, a ton of just very, very high value care per your last conversation. And the data I wanted to put in front of you, which, excuse me, is something we all know, but I think it's worth emphasizing here. With this litigation, you have both the coverage of this list of very high value services at risk, both the coverage and the cost sharing. And so when we get into implications of what might this mean for payers, I think there's a lot of folks who will have the reaction of course, people are going to continue, or plans and employers are going to continue to cover this list of really important services. Coverage, might not be the question. For me, I worry about losing the cost sharing protection of this provision. And the reason I worry about it is because of the data you see there, which is we know any type of barrier, cost barrier in particular, is going to throw up a hindrance to getting the preventive services that we're trying to incentivize people to get. So we've seen all this progress in part because we've reduced costs so much by making this without cost sharing. I worry that we're going to sort of return to, really significant out-of-pocket costs for people to be getting their preventive care. So the lawsuit itself, it's called Braidwood Management versus Becerra. You might have also heard it referred to as Kelly versus Becerra. I could tell you why the name changed if folks are interested, but this is the case. I think it's worth emphasizing, who the players are here. I find this to be a very ideologically motivated challenge, which is not a surprise in the Affordable Care Act, but I feel like it's important to just say that. The plaintiffs are almost all repeat players in ACA litigation. Many have brought prior challenges from everything from the contraceptive mandate to the employer mandate. They're represented by one of the attorneys is Jonathan Mitchell, who is the former Texas Solicitor General. It was his idea, and he's credited widely with coming up with the bounty hunter abortion law in Texas. He wrote a law review article sort of laying out that idea, and then folks ran with that. The other attorneys are represented by Stephen Miller's big legal institute or law nonprofit. So Stephen Miller, who's a former Trump administration official. So and this case has been brought before, Judge Reed O'Connor, who maybe folks know. I'm probably tracking maybe 10 court decisions before Judge O'Connor at any given time, but most folks recognize that name because he was the judge who declared the entire Affordable Care Act to be invalid back in 2018, and that's the challenge that the Supreme Court rejected by a vote of 7-2 last year. So lots of repeat players. I just think the context is important. I won't go into the detail on the legal arguments, except to say they're, again, arguing that the statute, that this provision itself, the Affordable Care Act, is unconstitutional. They're not going after the whole law this time, but they are going after the entire provision of Section 2713. They argue it violates the Appointments Clause, the Non-Delegation Doctrine, and the Religious Freedom Restoration Act. I guess maybe an editorial point for me is on each of those 3 legal issues, the Supreme Court and the appellate courts in general, I think are going in the direction of really expanding all of these doctrines. And so it gives me a little bit of pause that these are the arguments that are being made. I think to me, it makes this provision more at risk than we might otherwise think it would be in a different sort of legal and judicial environment. But trend wise, Judge O'Connor's decision here is not, I would say, out of line with where the Supreme Court has been going on these three issues. So I can dig more into that in Q&A if folks want. We got the decision from Judge O'Connor on September 7th. I've been sort of saying we got the first half of his court decision and we're still waiting on the second half to tell us what it means. But in terms of the substance, he went through each of those four categories of coverage, looked at each of those three entities, the Preventive Services Task Force, ACIP, and HRSA, and said immunizations from ACIP and women and kids preventive services from HRSA were fine, did not find a defect for now for those parts of the statute, but he did find that the way that the Preventive Services Task Force is constructed violates the appointments clause. And we can sort of dive in on that. The essential idea is you need someone when an entity is making binding legal decisions, and he takes the position that 2713 binds insurers and group health plans. When the task force makes recommendations, it is a legally binding requirement. Under the appointments clause, you need to have someone in the executive branch involved in that decision. And so the defect here is something that I think some of us might like about the statute, which is the task force makes a recommendation and it automatically goes into effect. 1 year later, that coverage is expected to be included in coverage. And here, there is no one such as, the HHS secretary who is responsible for saying, actually, I want to reject this recommendation, or I want to improve it, or I want to tweak it. Judge O'Connor, and I'm not agreeing with this, I'm just sort of explaining what the court said, finds that to be a problem. There's no sort of, you want political, the ability for political interference and oversight from the executive branch in some of these decisions. So did not find that defect for ACIP, and that's because ACIP makes recommendations to the CDC director. The CDC director can reject or adopt them, and the CDC director is overseen ultimately by the HHS secretary, so there was no problem there. On HRSA is an operating division within HHS. HRSA is responsible, again, to the HHS secretary, so no problems there, but the task force is too independent, essentially is what Judge O'Connor said. So a problem with the task force recommendations. I do not ascribe this to being only the task force recommendations. I think folks here probably know those are the recommendations which bring in the vast majority of that long list of 100 preventive services. I think there's more than 50 preventive services that come in through the task force. And so even if you keep ACIP and HRSA recommendations, you lose an incredible number of, again, the coverage requirements and the cost sharing protections for people. So it would be devastating, I think, if this, even if just what is maybe seemingly a narrow decision were to stand. Judge O'Connor went on to conclude that one of the employer plaintiffs, this Braidwood Management Company, that it violates the employer who owns the for-profit company objects for religious reasons to the coverage of PrEP, a very high value HIV prevention medication, for reasons we can get into, and Judge O'Connor credited that objection. This is sort of an extension of Hobby Lobby and the employer objections to contraceptives. We've seen this in gender affirming care as well, and now we're sort of seeing it get extended to PrEP. I think one point I want to emphasize for this group, a lot of the media coverage was about this part of the decision and the sort of religious objection to PrEP. That is all well and good and is worthy of discussion. I would emphasize that part of the decision only applies to one employer at this point. And we only have PrEP as a coverage requirement because it's recommended by the Preventive Services Task Force. And so something I've been emphasizing with the media that I talk to is you're really focused on this one employer for religious reasons, but if Judge O'Connor's decision stands, you lose PrEP for everyone, regardless of whether you have a religious employer or not. So a little forest for the trees there. I mentioned, and then I will get into the implications and then stop talking, We only got sort of the first half of the decision, so we know what Judge O'Connor thinks about the merits of this, and he finds a problem with this part, but not this part. What he didn't tell us is what it means. And so instead of sort of, normally you would say, I'm issuing a nationwide injunction, or I'm only setting it aside for these plaintiffs, et cetera. He didn't do any of that. Instead, he said, I need more information. I want to do additional briefing. And so we asked the parties they're going to go through this process of providing him more information about the scope of relief, which is this going to be a nationwide injunction to say on a nationwide basis, the Preventive Services Task Force recommendations should be set aside and are invalid. He's going to look at the standing of the other plaintiffs. It's 2 employers and I think 6 individuals. So he wants to hear more about their positions on this. And then I think there's some religious freedom claims about the contraceptive mandate that are coming our way too. Last week, I want to say, he finalized a briefing schedule. And so you're sort of going to see the back and forth between the parties in a way that would extend till mid-January of 2023, which means we're not going to have a decision. We're sort of going to be in limbo on this issue of exactly what his decision means and how far it reaches until mid-January. From there, he could schedule a hearing or he could issue a decision. But the point is that this is sort of being extended out. I would emphasize that, coverage remains stable in the meantime. He has just sort of said it's unconstitutional. He hasn't stopped anything. He hasn't blocked anything. He hasn't sort of issued an order. So it should be status quo for everyone in terms of coverage and cost sharing. But I think this sort of extension of the timeline really increases the uncertainty around what we're doing. So it's going to continue to be an issue to watch. Unfortunately, it makes it really hard to explain to people. So I'm thankful for the opportunity, but I think there's going to be much more to come in January. And I have hinted at this, and this is my last slide, and then I'd love to entertain your questions. If Judge O'Connor's decision is upheld, again, you have both the coverage of these high value services at risk and the cost sharing protections. It would essentially become voluntary for plans and issuers. You would see folks picking and choosing. You would lose the benefit of the standardization that we've had over time. Again, I think the coverage of many of these services, I wouldn't expect to go away, and perhaps for some of them cost sharing as well. But you already have, stories, and I included 2 examples there of employers and issuers being on the record saying, we wouldn't want to, but we would probably reconsider our coverage, right? Under pressure to compete against other plans, we would probably take a look at what coverage and cost sharing mean as a way to reduce premiums. And so it would lead to all this uncertainty. It would lead to a lot more variation. And then, for other groups, I don't have to emphasize the connection between higher out-of-pocket costs and utilization, but all of those things where we've made so much progress over the past 12 years, you would really see those gains be eroded. And so in terms of timing, again, 2020 coverage is stable. 2023 coverage, certainly for kind of calendar year coverage, it should be stable. I do worry about some of the employer market where you might have an off calendar year renewal. And if you're waiting to see the timing of Judge O'Connor's decision, what happens there? So keeping an eye on sort of the timing of his next decision. After he issues his decision, it will inevitably get appealed to the 5th Circuit. One question is whether Judge O'Connor will do what's called a stay of his decision while it's on appeal. That's what he did in the last big ACA case, right? So nothing was disturbed, everything went on, even as the case went up to the Supreme Court. I hope the same will be true here, so that coverage is not disrupted and that people continue to get the benefits under 2713 while the courts figure this out. But that's a key issue that I will be watching for sure. So that is all I had for you. I will stop there, and hopefully that is what Mark and Mike wanted me to cover, but would be happy to dig in. Thanks.
Thank you, Katie. Good gosh, I know you've gone over some of this with us before, but it still takes my breath away. And you go from egregious thing to egregious. The PrEP thing, I just forgot that PrEP was on the table as well, among egregious things. So if you don't mind, I want to go back to something that was on your slide, which was in the lower right-hand corner, which asked what payers would do. So I want to turn this back to our attendees today and just kind of glancing down the list. Good gosh, well, we've got AHIP here. We got a couple of great Blues plans. We got PBGH, we got Cigna, we got Anthem. MBGH, we've got payers, we've got employers, and if folks don't mind my asking, what might you do if the Supreme Court of the United States upholds all this stuff? Does anybody have a comment or reaction, whether you are a commercial insurer or an employer or an employer group? Does anybody want to kind of venture a position on that? And while I'm looking for raised hands here, I'm looking for some brave raised hands. Kate, I just want to call attention to a couple of things. I really appreciated your point about how this action is kind of jumping over statute and regs to the Constitution, the constitutionality itself. I didn't appreciate that before. And then the distinction about coverage versus cost sharing. Even if plans still continue to cover, which we hope they would, cost sharing still up in the air, and we could get into trouble there, and all the stuff we've been talking about with regard to equity could just get blown away. So Cheryl Larson has the first brave hand up, and Fendrick as well. Cheryl, what do you have for us?
You know, we've talked about this before, and our members in general, I can't speak for every single one, but our members in general would not change their internal policies about covering these at no cost because of the importance to the health of the individuals. And, you know, in terms of, they've worked around it. And in fact, a lot of my members have added services to the preventative benefits list, a lot of services, drugs, other things, because they knew how important it was. In terms of out-of-pocket costs, you know, if they're restricted from, which they can, I mean, it's their plan design, their grandfathered members, they're self-insured. So that's my 2 cents. Great job, Katie.
Thank you, Cheryl, on that. Mark, did you want to pose? I think you and I had the same question in mind. You put it in the chat as well. Mark, what do you have?
So, Katie, thank you very much. You know, as you're right, every time I see you, I get more and more depressed, but I do enjoy seeing you, and it has nothing to do with you personally. So I would love to call out, as I do in my classes, there's several people on the phone who I would love to just hear whether you're going to take the approach that Cheryl mentioned, or a more thoughtful one, given the pressure some of you or all of you might have on premiums, and the fact that if you make people pay less for something, they buy more of it. And particularly in the individual marketplace where some of you are, that's absolutely critical. But I do want to say, Cliff, that soon, and you know, this is kind of my off-Broadway, thanks to Ali Lapidus and her friends at Pharma, Paul Franson, Chris Roebuck, and I have done some really, knowing this was coming, analyses on what the costs of these 50 U.S. Preventive Services Task Force services actually do in terms of premiums. And it shouldn't come as much of a surprise that it's not a big part of total cost of care. And when you look at what change in total cost of care would be if they were to impose, say, a 20% coinsurance, which would be a standard type of cost share for them, particularly for the medical services, which are the majority of those covered, they would barely be seen. So the other and last point I'm going to make is, Cliff, you're one of the few who've been around from the days when VBID was called the benefit-based copay. We have to remember, Cheryl, kudos to you and Karen and PBGH, et cetera, that the private sector and the large employer sector was the sector that drove VBID, and VBID was not politicized until it became part of the ACA. And that's why I try to remain a little bit Tiggerish as opposed to my colleague, the Eeyore, of what might happen, that right-mindedness, the right thing to do, and equity-enhancing policies will remain in place for the most part, as opposed to what all the evidence would suggest if we'd go back to the future and where we were prior to the mandate of preventive care.
Yep. Thanks,
and Mark, I might just to jump on that and connect it with something Cliff you said about, again, if there is a constitutional defect with the statute, it will take an act of Congress to fix it. And so that is an idea I've been trying to, socialize with folks early, because of the sort of trend line I was talking about with the appointments clause, the non-delegation and RFRA and all these other things. I do worry that even if this does get all the way to the Supreme Court, which may or may not happen, that they might also find a problem with this provision. And so, Mark, to your point, I think ramping up the bipartisan support, talking about this in a way that's helpful, it might be needed. There might be sort of a congressional change that is needed here. I also think to the extent you all are doing policy around low value care, being very cautious about this, right? And ensuring that there is maybe a decision maker in the executive branch as you are going through this, you know, on other policies too. So a bit of a cautionary tale, perhaps.
That's why I rely on as many Katies as possible. I'll take all the Katies on this call to help us move this forward from both congressional and executive branch section.
Absolutely.
Thanks.
Well, thanks. Let's go to Jeff, and then Karen's up as well. Jeff, what do you have?
Thanks very much. And Katie, thanks for all of your reporting on this and helping be sure that we all stay smart about it. I'm just sort of wondering, since the judge didn't object to ACIP, since their recommendations must be approved by a Senate confirmed CDC chief, why doesn't the Biden administration just declare that the U.S. Preventive Services Task Force recommendations must be approved by the Secretary of Health and Human Services and basically make the whole point moot? I mean, it I mean, as you pointed out, congressional action seems really hard, and this seems like a silly technicality. And you know, is there a reason why one can't come up with a silly resolution to a silly technicality?
No, I think you are exactly on point, and so on point, in fact, that is what the Biden administration argued. So, you know, Secretary, and I should emphasize, right, this provision, this lawsuit started in 2020. Department of Justice under the Trump administration defended it. Now the Biden administration is defending it. Again, there's strong support for the importance of this provision. Setting that aside, Secretary Becerra came in, and one of the first things he did was signed a document saying, I, as secretary, approve all of these current recommendations that are in place. That ratification, that like one-page document that then got filed in the litigation, it worked for ACIP and it worked for HRSA. The challenge with the Preventive Services Task Force, Jeff, is that in the separate statute authorizing, sort of creating the task force itself, there is, I think, what at the time, and I don't know if Mark wrote this statute too, and if we're going to blame him for this, but there's a provision in the task force that says we don't want any political interference in the task. There's sort of this provision that makes the task force extra independent relative, certainly to ACIP and HRSA, which are very much, I think, connected to HHS. And so this came up in the litigation because one of the things that the Department of Justice said was, hey, Judge O'Connor, if you think there's a problem with the task force, you don't have an issue with the coverage requirements. You don't have an issue with 2713. If you have a problem with the task force, strike down that political non-interference provision, strike that, get rid of that. That would allow the secretary to sort of fully be in charge of the task force recommendations. So they said, don't even mess with 2713. Look over here, change the task force. Judge O'Connor has already suggested he doesn't buy that argument, but it is something that I'm sort of thinking maybe on appeal or on the remedy or something like that might be a new issue that we see. But Judge O'Connor didn't seem like he was buying it. So you're on track, but I think a very well-intentioned provision to say we don't want political interference in this evidence-based process as we create this task force is now causing a little bit of a headache over here.
There are the two sides to that coin. You're right, Katie. Let's take our last comment on this. Karen, let's go to Florida Alliance with you. Karen?
All right. Well, I have to say that I missed the full implications of this until you did your presentation, Katie, because we've been focused on so many other things, and especially lately in Florida, as you know. My hope, Mark, is that our employer members, because VBID is so important to them, that they wouldn't back down and they wouldn't, fall into the, cost share for these important services. But I think, we really need to double down. I saw a lot of great articles in the chat. I hope the links can be sent to us to put something together to really educate the employers and make sure they understand how valuable these services are. I mean, we've certainly told them over time, but I think I've got to get something together that's very succinct, get their attention on it. My concern would be that some of the health plans or TPAs they work with might not be is on board as they are to VBID. I hope I'm wrong about that, but we have to make sure part of the action that the employers take is that, they get in lockstep with their health plan to make sure, that they can stay the course with, these services being free and very accessible. There is an increased awareness of the health equity factor, and I think we have to throw that in there too. The other thing, real quick, I won't take too much more time. I actually have to jump off and go to another call, but the National Alliance of Healthcare Purchaser Coalitions that, the coalitions that are on here now are all members of has a health policy strategy group, and we haven't talked about this yet. So I really do want to put that in front of the chair of the group and Mike Thompson so that we can get the word out across the other coalitions. They may be able to put an action brief together, and Cheryl or Denise or Randa, I don't know if you've seen anything from the National Alliance, but I have not. But I feel like we need to get on this right away.
Thank you, Karen, very much. Well, Katie, any last words of wisdom or glass half full stuff, please? What's your give us a take home comment for us all.
No, I think those, just hearing from you all, having it on your radar, knowing you're being thoughtful about it, I think is very important. The truth is there's a bit more to come. And thanks for having me on. It's the fact that it's not the whole statute makes it complicated. The fact that we don't have the second half makes it complicated. So thanks for sort of being on the journey. And please, anyone on this group should consider me a resource. I'm very happy to help, whatever you need. And just thanks for having me and putting it on the agenda. I think it's super important.
Well, thanks, Katie. Actually, I'll flip that back to you. I hope you'll consider the folks on this call be resources for you in carrying this forward. Gosh knows, we need for you to stay on this issue, please. And if any of us can provide any sort of assistance one way or another, please let us know. We can't let this one go. Thank you so much, Katie Keith. You will be coming back again, I'm sure, and maybe next time with some even better news. Thank you so much.
Thanks, everyone. Bye.
Right. All right, so we're going to take you, I'm giving folks just to the bottom of the hour. I want to stay on track here. Let's take an 11-minute break, and when we come back, Aaron Schwartz is going to be all queued up. He's got some threads to pick up from a couple of our previous speakers, and he's going to take us a little bit into the future, what we're looking for analytically to make a stronger case all across the board here. So we'll see everybody back here at the bottom of the hour, and Aaron Schwartz is going to lead us off. See you then. Well, Aaron, as I know you have realized, it's already been an eventful day with quite a few insights. Sometimes it's 2 steps forward and 1 step back. We just heard something that looked like 3 steps back with regard to that legal action. But maybe you can take us 2, 3, 4 steps forward, Aaron. I know that you've got many threads to our previous speakers and a lot of other folks on the phone. And so you bring to bear a lot of background knowledge in this and expertise. And so tell us about the challenges and opportunities. Aaron Schwartz.
Well, thank you so much. It's great to be here, and thank you everyone for your attention. So I'm a researcher at the University of Pennsylvania. I'm a health economist and general internist and do my clinical work at the VA. I just want to put out front, this is not a research talk, so I'll be more sharing opinions of mine as someone who has had a large portion of my research agenda devoted to low value care. And this talk contains basically reflections of things I've learned and where I think we could go as a field and what we need to learn more about. I'll first want to acknowledge some of the work that I'm presenting today. It's the fruits of labors of many collaborators, and it's possible because of funding from multiple organizations. I'll keep it simple in terms of my goals since we don't have a great amount of time. I want to describe some of my research agenda on reducing low value care, but more important than that, I want to inspire you to pilot new strategies to reduce low value care. And I'm explicitly making the pitch that I'm interested, and my team is also available to help conduct rigorous studies to evaluate how helpful these projects, these strategies to reduce low value care are becoming. And I think one of the take-home arguments that I'm trying to make in this talk is that we really do need rigorous evidence on what can successfully reduce low value care and what the side effects might be. So more on the maybe inspiration front, I like to start one of my health economics courses with this quote and this somewhat maybe extreme claim that every US problem is a healthcare spending problem. So I think the quote that best demonstrates this is not actually a quote about healthcare, but a quote about military policy. It goes like this. So every gun that is made, every warship launched, every rocket fired signifies in the final sense a theft from those who hunger and are not fed, those who are cold and not clothed. This world in arms is not spending money alone. It is spending the sweat of its laborers, the genius of its scientists, the hopes of its children. This is not a way of life at all in any true sense. It is humanity hanging from a cross of iron. Now, this was a quote from President Eisenhower, and he was speaking up against what he saw as excessive military spending in the post-World War II era. And if you look at the scenario that Eisenhower was facing, you can see, and all these figures are adjusted for inflation, that he was in a world where less than $3,000 per person per year were being spent on military spending. And nowadays, we have about $12,000 per person per year being spent on healthcare spending in the United States. So we're investing far more of our resources into healthcare now than was going toward the military in this time when Eisenhower signaled this alarm. And that would be fine if we thought we were getting a great deal in terms of our investment, a good return, good value. But there are some reasons to think we might not be. And so this is my favorite study on low value care in the last year. It is not one I was involved in, but involved some of folks that I was lucky to call colleagues at Harvard. This was a very simple study where they looked at the amount of spending on ivermectin prescriptions during the COVID-19 pandemic and found that commercial insurers were spending about $130 million a year in aggregate on this drug that we now know is useless. And the big puzzle is why. What are the reasons that this is happening? And I think it's helpful to think about this puzzle in terms of three potential domains of causes. And I think they all can be important in different settings. So one is knowledge. So you might think, well, maybe at the time the clinicians didn't know this was useless, or the insurers didn't know it was useless, and just there wasn't enough information there. That's possible. The study was done during a time in the pandemic that was fairly early, but there were already some randomized trials showing that ivermectin didn't seem to help. So maybe that's not what's going on here. The second domain is incentives. And you might think, well, even if they had the knowledge, if they weren't, if it wasn't in their interest to act on that knowledge, maybe it wouldn't have happened. But these are private insurers. They're in a good position to make money if they can eliminate wasteful spending. So maybe that's not really what was going on here. And then the third domain that I think is important is kind of a big bucket, but I'd call it implementation. Maybe the knowledge was there, the incentives were there, but just the insurers didn't have the ability to execute their policies in a way that was effective. And so I think these three domains represent the key challenges and opportunities for reducing low value care in the U.S. healthcare system. And I think they're all important. On the knowledge front, I think the real challenge is just how can we learn what is low value and teach others what is. And I think this is arguably the most important domain because ultimately, the quality of every healthcare decision rests on the knowledge base that went into that decision. If we know what is high value and what is low value, and we know that based on strong evidence, we're in a much better position to make good decisions. Whereas if we don't have that knowledge, if we make good decisions, it's going to be by accident. Next is the incentives. And the challenge here is how do we reward agents for doing high value things? And I think it's important to remember we're not just talking about one agent like a doctor, but there are a lot of people involved in clinical decision making, patients, insurers, regulators, and we want to make sure that they all are benefiting from a high value scenario. And now I know there's been maybe less enthusiasm these days for pay for performance and efforts to directly tie incentives toward hitting certain benchmarks. But I think it's important to highlight the contrast is, when bad incentives exist, we really don't expect to have good results. I think this was put well by Upton Sinclair, who said it's difficult to get a man to understand something when his salary depends on his not understanding it. So if we have scenarios in the US healthcare where doing the high value thing means losing a lot of money, I think it's safe to assume that we're not going to see a lot of the high value things. And then next up, where I think there's really a lot of innovation room, is implementation. How do we promote high value care effectively without harmful side effects? And I think the opportunity here is really that I think the American healthcare system has accepted that managed care is here to stay. The era of insurers passively reimbursing providers based on submitted claims, and that being the beginning of and end of their job, I think is over. And so if we have managed care, the question is, do we want high quality management or low quality management? And investing in high quality management is a choice that I think we could make. So these are the three domains where I see we need to kind of build, but we have opportunities to build. And then I'm going to move on and talk about some lessons I've learned from my my research agenda on low value care. So lesson number one is that measuring will only get us so far. So I spent some of my time working on my PhD dissertation developing process measures for detecting low value care. And a few things became obvious in that first year of work. First was that it's not clear that just because something is measurable that it's important. So we were only able to develop a few dozen measures for detecting low value services because those were the only services we thought we could do measurement in a reliable way. But that doesn't mean that that's where all the important low value care is. The second thing we learned is that how these measures performed depended a lot on how we defined what a low value service was. And if we used broader measures, we caught a lot more services than specific narrow measures. And I think this can lead to some frustration because it's clear that measures of low value care are not going to be appropriate tools to fix every problem in healthcare. But I think the bright side is that there are many settings where we don't actually need highly validated, administrative-based claims measures to achieve high-value results. You can think about the ways in most industry settings that we have managers that infer the quality of the performance of their employees without necessarily resorting to some standardized metric, just by observing how a clinician in a practice is practicing medicine, reading their notes, talking about their decision making. There are a lot of kind of qualitative ways to encourage low value care without resorting to these kind of measures. The second lesson is that benchmarking against the highest performing folks will only get us so far. So I've participated in a lot of studies that have sought to measure where is low value care and is it different in some places than others. And probably the most persistent finding that we found is that there's a lot of variation in low value care, but it's substantial even among the best performers. And this was true in studies where we looked at high and low performing regions, high and low performing provider organizations, individual physicians, VA medical centers, insurers. Really, no matter where you look, there's going to be variation, but there's also going to be a substantial amount of waste that we're measuring even among the better performers. And so what that means is that benchmarking approaches and trying to eliminate variation, it's not going to eliminate all the waste that we have in the medical system. We need to think about systematic interventions where we're hoping to change decision-making for a broad set of providers, not just people we think of as outliers in practicing poorly. And the last lesson that I wanted to discuss before jumping in more to my research agenda is that I really think we need high-quality evidence on scalable strategies to reduce low-value care. I think there's a lot of great work that could be happening in this space that we haven't seen yet. And the reason I think this is so important is that I found in my own research that low value care is a very sticky problem. So I've got work that's under review right now showing that rates of certain low value services didn't really budge even in this world changing pandemic that we've been living through. So if something as massive as a pandemic is not budging things, that shows that this problem is not going to go away by accident, probably. Another realization I had is that low value care can be thought of as several different problems. So this can refer to services that are known to be harmful, some services that we just suspect are harmful and might be harmful in some settings, but not others, or we don't have evidence. There are certain services that are low value because of their current price. It's just too expensive, and other services that are low value at any price. And once you realize that you have different types of problems, they might be amenable to different types of solutions. Certain tools might be most appropriate for scenarios where we are highly certain that a service is harmful, and we could institute a coverage restriction that's pretty blunt, or maybe we just want to nudge something that is going to get clinicians and patients to think twice about whether a service is really necessary. So this is a hard problem, and hard problems are going to require strong evidence, careful solutions. We really will want to know that what we're doing to affect low value care is producing the results that we hope to find. So with that, I'm going to shift a little bit toward a area that I've been interested in studying lately, and I'm hoping to study more in the future, and that's coverage policy. So as a health economist, I'm always drawn back to this seminal article that was written by Ken Arrow in the 1960s, where he touches on a lot of issues that all became kind of core issues in health economics in the subsequent decades. And he kind of touches on coverage policy in this article, where he says, by certifying the necessity of a given treatment or lack thereof, the physician acts as a controlling agent on behalf of the insurance companies. Needless to say, it is a far from perfect check. So here he's highlighting this basic tension, which is that the insurers have limited information about whether a service being delivered in an office is valuable or not. And they might have a hard time writing that into their contract. But coverage policy is one way that you can do this. If you restrict coverage for unnecessary services, you're directly addressing the market failure by saying, we are not going to kind of send a blank check towards services that are wasteful. We want to know specifically that a given service meets certain criteria before we want to pay for it. But this doesn't come without disadvantages. So there are the compliance costs for providers, enforcement costs for insurers, and potential delays for patients when you institute coverage restrictions and have to enforce them. This might be a little elementary for this group, but I just so that you are all clear on the terms that I'm using, I'm going to just walk through an example about how coverage policy can play out. So this is my favorite television doctor, Dr. Spichemin from 30 Rock. And let's say Dr. Spichemin sees you and you have diabetes, and he decides you need surgery for your diabetes to remove the diabetes, and he would like to get paid by the insurer. So he these days likely would need to go to the insurer first for a prior authorization to approve this service. And then if that approval was granted, then he would perform the surgery. Then he would submit a claim to the insurer. And if that claim was approved, he would be paid. So there are ways in which coverage policy could restrict him from performing this unnecessary service along the way. His prior authorization might be denied, or it might go through and then a claim submission subsequent might be denied. And I call that a clinical denial because it was based on some clinical criteria for what a necessary service is. He might also have the claim denied on administrative grounds. So maybe there was a typo or was a duplicate claim, but that's not really what I'm talking about here. And then one happy ending to this whole tale might be that he never sought a prior authorization in the first place, never performed the service, and the service was deterred, which is the lowest cost option for this outcome and one that results in no patient harm. So that's kind of what we're hoping to accomplish by having coverage restrictions. Now, this seems like a good way to restrict low value services potentially, but a problem is it's not been uncontroversial by the least. So the AMA has had a persistent effort to lobby against prior authorization. Here's a tweet by the AMA talking about how prior authorization can have alarming consequences for patients delaying or denying evidence-based care. And there's even been some agreement across different industry groups within healthcare that there's scope to improve prior authorization and the prior authorization process. States and the feds have also stepped in to try and change this process. There are gold card programs that have been legislated in certain states where it is illegal to require prior authorization in certain circumstances for high-performing clinicians in terms of those who have been approved a lot for their prior authorization requests. And I'm speaking to you today from Philadelphia. We have a state bill in play that would increase regulation of prior authorization. In Congress, we've got HR 8487, Improving Seniors' Timely Access to Care Act, which is a bipartisan sponsored act that's out of the Ways and Means Committee. It focuses on prior auth in Medicare Advantage and would institute certain requirements to speed prior authorization, make it electronic, et cetera. So this is an area where there's a lot of interest in changing the rules. But there's a lot we don't know about coverage policy restrictions. And so that's what I'm trying to study and where I think there's room to grow scientifically and as a healthcare system. So basically 3 questions I'm trying to help answer with my ongoing research agenda. One is, are these coverage restrictions extensive? Because if they're a big part of the healthcare system, that means something different than if they're not. What do the coverage restrictions accomplish? Are they producing a lot of savings without unintended consequences? And how can we improve these policies? So I think these are kind of the 3 core unanswered questions when it comes to coverage policy. And I'll share a little bit about where I've gone in this direction. So I think the preliminary answer to that first question is yes, coverage restrictions have become extensive. And where I've been studying this, the case study has been in Medicare Advantage versus traditional Medicare, because traditional Medicare really has minimal prior authorization. There are a handful of demonstration projects that have been scaled in traditional Medicare for prior authorization, but it's really not a substantial part of the program. Whereas in Medicare Advantage, prior authorization can be extensive. So I did a study in collaboration with folks at CVS Health and Aetna, including Dada, I saw on the call. So she's a co-author on this paper in JAMA Health Forum, where we looked at all of Medicare Part B spending and said, what proportion of it would require prior authorization at Aetna? And it was a large proportion. It was a quarter of all Part B spending. And a lot of that was from Part B drugs or injectables. So in that one case study of looking at Aetna MA, we could see that there was this very large gap between how Medicare and Medicare Advantage firms are approaching this issue. Now, so this is preliminary work, so I'd appreciate you kind of keeping it to yourselves for the moment, but I'm currently replicating this work with multiple insurers. So these are 5 MA insurers. Aetna's in the mix, but so is Humana, Cigna, WellSpan, or WellCare, and I'm missing one. All right, it'll come to me in a minute. Anyway, what you can see is that a large proportion of Medicare Part B spending would require prior authorization at each of these insurers. So the individual insurers are A, B, C, D, and E here, and that's between around 18% and around 35% of Medicare Part B spending requiring prior authorization. If you look at all the Medicare spending that would require prior authorization at least one of the insurers, you're talking about more than 40% of Medicare Part B spending. If you're looking at the areas where there's consensus and every insurer requires it, that's a considerably smaller number, around 12%. So there is a lot of prior auth out there. Here are the top spending services in Part B in terms of services requiring prior auth. And you can see a lot of Part B injectables here, but not entirely, some services in the mix as well. And just the top service, aflibercept, that's responsible for over 2% of Part B spending. So, so this is where MA plans think there might be room to cut back on low value care potentially. But the benefit of these restrictions isn't totally clear. So in another study we did looking at denials in Medicare Advantage, we found that these denials were somewhat rare. Less than 1% of MA spending is denied on coverage grounds. And so what this means is that if coverage restrictions are producing big savings, it's probably in the deterrence. It's probably not in denying claims for services that already occurred. So we still need to find out what the extent of that deterrence is. There's also some extent to which we need to learn more about what the denials are accomplishing in terms of which denied services are low value. One finding from this paper that I found interesting is that traditional Medicare's own laboratory reimbursement rules prohibited reimbursing for hemoglobin A1C tests in many circumstances. It was one of the most frequently denied services. And I think you'd be hard pressed to find a physician who thinks that A1C tests are a big source of waste. So I think this is a case where there was an old rule that Medicare had that maybe made sense when it was first created, perhaps when these tests were first coming to the market, but that rule hasn't really kept up with the state of medicine and how it's practiced. So I think, to me, this emphasizes that coverage restrictions are not just about new shiny services, but about making sure that our rules for older services align with how medicine is practiced today. So this figure just highlights that one service and also points to some of the other types of services that are being denied on the basis of Medicare's coverage rules versus private insurers' additional coverage rules. Talking about a little more on what's next for work. So I'm really interested in learning about what coverage restrictions can accomplish. And if we want to look at what coverage restrictions can accomplish, it's best to look at changes in policies regarding coverage restrictions. So I've got ongoing work also with Aetna examining a change in its policies for some of these high-priced injectable drugs for ophthalmologic use. And trying to understand what was the effect of those changes on service utilization, spending, offsetting services, things like that. And I'll close by talking about how, if we want to learn what these policies do, one way is to make more policy changes, to experiment, to try new things and see what happens. And so this is my white whale of a project, one that I'm really hoping to happen, although it's not in the works quite yet. But it comes from this observation. So prior authorization has some administrative burden, but the main burden is the approvals, not the denials. The vast majority of services tend to be approved, but they still need to go through the administrative process. And so what that means is, ironically, the only people that don't have to deal with prior authorizations are the docs who know that they're going to do something that's going to be denied and know that what they were planning to do is an inappropriate service. They don't even go through the prior authorization process because they realize it won't result in a good outcome. But the good actors, the ones that we think are practicing higher value care, have to go through the process anyway. So this raises the question of, where can we eliminate prior authorization where it's not necessary? How can we focus this process, this policy on really the highest yield settings? And this is something that I think is very studyable. So you basically would work with an insurer and target a particular service or service line that's subject to prior authorization, create criteria for exemption where you think certain providers don't need this because they're unlikely to perform low value services, then exempt some qualifying clinicians, not others, and see what happens. Study the effects on spending, use quality, et cetera. And I think this will benefit insurers in multiple ways. In some ways, even if regardless of what the reform actually accomplishes, because if the reform succeeds, there's an obvious success there. You've reduced administrative costs, reduced hassle costs, and innovated. But even if the reforms fail, we've learned something really valuable, that these kind of coverage restrictions are valuable even for high-performing clinicians, which would be very strong evidence that these are important policy levers that our insurers are using. So I'll end with a plea that if this sounds interesting to you, call me. Operators are standing by, as they say, or used to say, I guess, in terms of things I might be interested in. But I'll close there, and thanks so much for your attention.
Well, thank you very much, Aaron. Very helpful, and glad to see that you're trying to push the envelope here on such aspects as prior auth and using real data. Just sticking with the prior auth part, nobody doesn't hate prior auth, it seems. You don't see people just staking their careers on and so forth and saying it's really necessary. Is there at least a way to further perhaps automate prior auth? How much prior auth really is automated at this point, and are there opportunities to even get into maybe a little bit of machine learning for prior auth or something else to reduce that burden and maybe come up with a viable list of gold card members, for example? Anyway, any movement in that direction?
Yeah, so I absolutely think that's the case. So I think prior authorization could even be useful if it were a pain in the butt, so to speak, in that, you know, certain ordeals can be what economists would call efficient because they help, you know, the fact that a clinician is going to go through some extra administrative hoops to get something for their patient signals something about the use of that service. I think the hope is that there are less annoying and costly ways to accomplish the same thing. And that's hopefully why coverage rules are based on actual clinical rules. And they don't ask docs to say, solve a Rubik's Cube before they will get something paid for, or something that has nothing to do with clinical medicine. You know, you could institute an ordeal that way. Instead, I think the hope is that these rules are based on real clinical insights about what's valuable and not, and any rule that confirms that a service qualifies for based on those criteria should be as easy as possible to get done. So I work in the VA. So my experience with prior authorization is all kind of internal to the VA health system, but there's a lot of utilization management. It just happens in a different way. So, you know, before I order certain studies, I have to check some boxes affirming that certain things are true, and that they meet criteria. So that's one way of doing it. You could imagine a system that relies more on trust and verify, where there's an audit capacity where you don't require approvals, but if you audit and find that there are problems, then you ratchet up the requirement, the administrative requirements to get approval or things like that. There's, you know, the gold carding type approach of saying who do we think is high value in terms of what services they're performing, and kind of exempting certain folks from prior auth restrictions based on that, or based on the risk contracts they're under. Why do we need prior authorization if we have high incentives for patients or for certain providers to reduce spending? And why don't we just leave it up to them how they're going to do that? So I think there's a lot of possibilities, and I think there should be a lot of experimentation in this space, given, as you've said, there's not exactly a very popular policy. So if there's ways to make it better, I think it would be seen as a win-win across parties in healthcare.
Yeah, the win-win would draw you a lot of applause if you could pull it off, Aaron. I see Mohammed Saeed has a question for you.
Yeah, I think that, it's a great idea to, how do we embody all the knowledge from rules and the guidelines. But even if you look at a lot of these guideline documents, some rules are very easy to codify and, create simple rules around them. But many guidelines also are, several paragraphs in length. But they are still very important and have, profound impacts on patients. So that's where, we've been trying to look at this problem in terms of how do we really understand each patient and all their characteristics and whether a procedure is indicated for that patient. A very simple rule, for an asthma patient being on albuterol inhaler or something like that might be very simple to code up. But, 2 paragraphs of text and then turning that into a rule that's equally applicable to a broad patient population becomes very difficult. So I think this going back to Cliff's point about machine learning or other technologies, I think this is where we've been trying to look at other ways of identifying each patient based upon their personalized characteristics, and looking at the providers from the perspective of, are they doing things to patients in a manner which other providers would be doing that, or are they acting in a very anomalous pattern? So similar to the gold card, maybe there are also the providers that actually are outliers who are doing things that are not indicated or no value or potentially adverse impact for patients.
Yeah, so I think you've raised a bunch of points. I think to jump on a few of them, I think we probably can learn something from high outliers. You know, once in I feel like it's kind of twice a year, the Office of the Inspector General will announce some conviction of a clinician who's been performing very dubious medical practices at some unheard of rate. And it makes you wonder, like, how did this not get caught earlier in terms of, like, if you're in the 99.999th percentile of some procedure that, you know, maybe it's suspicious. But ultimately, you need to examine clinical services against some criteria of, is this a good decision or not? You know, you can't just rely on high versus low utilization. You have to have some kind of medical knowledge that's based on how you're evaluating folks. And so I think you can't always escape that complexity of, you know, how do we determine what's high and low value? And in some ways, that's the mission of clinical medicine, right? Is to come up with rules that are based on evidence. And sometimes the evidence is not great. And sometimes you need to go against certain rules. But that messiness is, you know, inherent to the medical exercise. And this is why I think growing knowledge of what is low value and what is high value is such a crucial part of the whole reducing low value exercise. And I think part of I see a question from Mark Friedberg that's related, which is, you know, why don't we know the answers to these research questions already, given the amount of dollars at stake? I think part of the reason is that there's not a lot of the knowledge gained from answering these questions is not going to be captured by an individual insurer necessarily. So I don't know that the incentives are aligned to figure out, you know, like if you say, if one insurer was to definitively figure out whether colonoscopies are helpful in the 45 to 50 age range using whatever, machine learning experiments, something, are they going to become drastically more wealthy? No, that's information that's going to be used by all payers, all doctors. It's going to change U.S. healthcare for the better, probably, if that's, you know, by expanding knowledge, but it's not something that can necessarily be captured. And I think that that's probably the case with a lot of this information. The reason I was able to study prior authorization policies of multiple insurers is because it's public, it's out there in the world. We know, like, you can find what your competitors' policies are. And so I'm not sure that optimizing on all these margins gives yourself a big edge compared to your competitors. So maybe that's why folks are not pursuing it as much.
Well, thanks, Ernie. You might want to take up Mohammed on some of those things he put on the table for you. Might not be a bad idea. Mark Friedberg, did you want to follow up? Mark?
Yeah, good to see you, Aaron. I think you basically answered my question, although I wonder if it's all explainable by the public good option. You know, that's possibly it, but you know, the dollars at stake, even for a medium-sized Blue Cross plan that I work at, are enormous. You know, we have 4,000 employees, all of whom can flip a coin. We have you know, many people doing information technology work, writing medical policies, and yet this is not, and I don't think we're alone in this. This is, you know, A/B testing and actually figuring out what works is not a part of standard operating procedure. So I'm wondering if, you know, if we can really say this is all because of failure to capture the full social benefits, or if we're even underinvesting, you know, within firms. And then I'll just point out, because you mentioned it, providers' position on the relative usefulness or evil of prior auth depends a lot on how much risk they're taking in their contracts.
Point very well taken, Mark. Thank you. Aaron, response?
Yeah, so I agree with everything Mark just said. So yeah, I was surprised to hear that, you know, some provider groups under full risk want the prior auth because they think it's a useful technique, which to me is actually somewhat sad, because I would hope that they have more efficient ways to kind of manage the care that's happening than something that can be as burdensome potentially as prior auth. But say la vie, that's the way it goes. In terms of investing in research, I mean, I literally, we had former Secretary of Health and Human Services, Azar, at Penn this past week, and I asked basically the exact same question that you asked to me, to him, related to COVID response, and that, you know, how is it possible that we made it so long without knowing what steroids did or whether the blood should be thin or not, and we're relying on other countries to provide this knowledge for us for like such important things on which, you know, trillions of dollars depend. Why are we not why did we fail to kind of produce that kind of knowledge? And I think we both just ended up kind of empathizing with each other that it seemed like we're failing at this and we're not sure why.
Glad you posed that question to Azar, I must say, Aaron. And thank you, Mark. Mark, by the way, before we leave you, Mark, what research direction would you like to see taken? You talked a little bit about your own outfit. What would you like to see uncovered?
Well, I mean, regarding prior auth, it's Aaron's white whale. I mean, this is on my burner as well, which is we need to do the RCT that would solve the policy issues that are currently being debated nationally and in various states around gold carding. You know, we don't know which one is better, and only data is going to tell us. So anything we do should be randomized. And I actually don't think these are necessarily substitutes. They could be complements. We should have one arm that gets both.
There you go. The RCT on gold carding. Next up, thank you. Hey, Jeff, back to you, Jeff. We appreciate your comment in the chat about, well, the deterrence issue. Do you want to pick up on that or something else? Go ahead, Jeff.
Yeah. I figured I'd ask the question directly, Aaron, since obviously, again, great presentation, and thank you for the important research you're doing on this. If we accept that the way prior authorization really works is deterrence, rather, doctors just don't order things because it's going to be too much of a pain in the butt to justify things that are really sort of hard to justify. I can sort of see that if if an individual provider never has denials, sure, gold carding them shouldn't have any impact. They're going to stay as they are. But for people sort of in the middle, if the hassle factor goes away, isn't the prior authorization going to become sort of non-useful? It's just not going to do the trick. I hate to say that as a doctor. I mean, I know all my colleagues deeply hate these, but it seems like the pain in the ass element of them actually ends up being part of why they work, maybe all of why they work.
Yeah, I think this is ultimately an empirical question. I mean, there are multiple mechanisms whereby this could produce savings. One is the pure hassle. Two is the kind of educational component, in that you're basically conveying like these are criteria for appropriateness. And I would say the third is what was it? The third is the incentives, the idea that you just might not get paid if you don't do the thing appropriately. So there's kind of that's kind of related to the other two. But I think it's an open question. I do think that clinicians are used to rules. They're like, clinical medicine is built on a lot of kind of algorithmic type thinking about what's appropriate and what's not. So I think it's not that this type of approach is foreign to how doctors think and how it can get done. So I think there is opportunity to try and build on that in a way that hopefully causes minimal pain for the many doctors who are getting approved.
We don't want to cause docs any more pain, I guess.
Thanks.
Let's go back out to state of Washington with Denise. Denise, what do you have there?
Oh, thank you, Cliff. So Aaron, I'm curious as it relates to pharmacy, right? The prior auth process, what we found is when you take that prior auth to an independent therapy, committee, that there's more denials, that there's misaligned incentives to approve the dispensing of the drug. So I'm just wondering if you've taken that into account and who's doing the review and what the motivation is to approving it.
So I'm sorry, what's the alternative? So when you say an independent group, you mean basically like subcontracting out the insurer subcontracting out their prior authorization processing?
Yeah, to an independent P&T committee. Mm-hmm.
Got it. I haven't looked at this specifically. I think it might make sense that there's specialization. I mean, there are whole firms that are related to prior authorization, and that's their business, and they kind of they perform prior authorization services for insurers, and so maybe there's a degree of specialization that happens there. I think it makes sense to some degree. I mean, Medicare has has the kind of MACs is my understanding. They're the ones that are kind of executing the coverage policy rules. And so, yeah, I think there are different potential groups, and it remains to be seen what their relative performance is. So that's kind of another potential lever to how we could optimize this system, is thinking about who's doing the work.
Thanks for that point, Denise. I hope folks will take notice. I really appreciate Dot's comments, as well as Mark Friedberg's reference with regard to 100% approved PA requests might still have a deterrent effect. Point very well taken. I'm just wondering at this point, Aaron, given the input that you just received, if you could concoct your next prospective study, RCT observation, what have you, for an intervention to determine the effectiveness or impact of prior auth, what study would you design? How would you lay it out, Aaron?
So I think it would be along the lines of some sort of gold card type study, where the focus is not to test the existing policies as much as against some standard that we think would be better. I think there's enough consensus, I think, that this is an area where there's room for improvement. So I think it would be great to set the bar in that direction, where we're looking at comparing an optimized prior authorization process to the status quo, rather than say, what's the effect of prior authorization that we see in private firms that's different than, say, Medicare. I think that's important also, but if I had my druthers, it would be towards kind of, let's make things better. How can we make improvements? And I think, like, I would love to pick something that is common, expensive, where clinicians have a substantial track record. And I would love to see basically how these prior authorizations, whether they're necessary for the high performing docs versus not. So I would want to have that kind of factorial design, where we're looking at those that seem to get a lot of denials versus those that don't. And then I'd also want to interact it with the payment side of things and look specifically at when they're under risk and there's already incentives in place, does the prior authorization add something in addition to that? Are those synergistic or moving in opposite directions? So that would be kind of what I'd be most interested in doing. And I think I think that payers should be motivated to do this, because otherwise they're going to be forced to run the experiment under the legislative rules that are set up in ways that might just be impractical. I mean, what I've heard about the Texas legislation is that the rules are not set up in a way that makes it even feasible necessarily to do the gold carding program. Some insurers might decide just to get rid of prior auth entirely in response.
Yeah. Well, in any case, what you just described a moment ago sounds like a pretty good roughing out of research protocol. So maybe you ought to kind of write that down. Before we leave this topic, I just want to pin this back on Mike Chernow. Mike, I know you've looked at this from sort of kind of a microeconomic as well as a larger macroeconomic viewpoint. How would you weigh in on this particular issue, and then we'll move on?
Well, I don't want to cut too much into Mark and Katie's time, but Aaron, thank you. My general question is, to what extent do you think the execution of prior auth is an important competitive advantage for plans, and that efforts to do things like gold carding or a whole range of other things will get to a point where the plans don't want to do it in a common way, but they all want to do it in their own way, because if they all did it in the same way, which might be administratively simpler, they wouldn't get the advantage from it. So they resist. So the plans resist certain types of standardization. I think prior auth could be a lot less burdensome if every plan had the same basic approach to all of these different things. But I think there's an argument to be made that that would be problematic from the plan's point of view, because that's where all the competitive advantages. And so, and if they change payment, as Will said before you, maybe they don't need to prior auth because they just, they're just not paying for it anyway, just because of the way the risk is being attributed. So I'd like your thoughts on how the fragmentation of the payer space contributes to difficulty in having an administratively effective prior auth world?
We're pushing you hard here, Aaron.
Yeah, no, this is a tough question from a former dissertation committee member of mine. So yeah, this is a tough one. I think, you know, it's obvious that there are a lot of complaints about lack of standardization from the provider side. I think I think there might be some short-term gains from insurers saying, hey, are you a high-performing provider who's sick of prior authorization? We've developed a new way that's going to be better for everyone. Come to our network. You know, I think there could be a competitive edge, but I do worry about that dissipating, since it's, I think, hard to kind of keep those methods proprietary and gain from them. I do think it's necessarily a space where coordination would be challenging, and a coordinated benefits system could be helpful in some ways, but it also could be sclerotic, which I think is what might be the case in traditional Medicare, where these rules are, yes, they tend to be uniform across most of the country in terms of national coverage determinations, but they're slow to come out, and they might not catch up when evidence changes. So I would predict that this is going to be an area where there continues to be experimentation and diversity in approaches rather than standardization. And my hope would be that would be for the better, because it shows how there's kind of innovation that's being accomplished. I will say, though, on the other hand, all this comes back to the quality of the clinical knowledge and medicine. You know, it's not the case that the medicine is going to be fundamentally different in terms of what helps patients and what hurts patients in one insurer versus another. So, like, I think there is a case for having somewhat similar standards in terms of what is considered high or low value. But I think where the innovation and diversity should occur is like how that standard is applied. What are the approaches to essentially the management of the managed care? Like how do you enforce the standard? Is it with something particularly harsh and blunt, or something that's kind of more nuanced? So anyway, I hope that kind of answers the question.
Well, he doesn't hold sway over you for granting your PhD anymore, but so you can push back on it. But in any case, Aaron, thank you very much for delving into all these issues. It would seem that you've sort of perhaps prompted some potential research partners, or suggested some ideas to others for research that they might pursue, and form partnerships accordingly. But please forge ahead. There's no shortage of work to do in this area. We really appreciate the opportunity to listen to you today. We hope that you'll give us a return visit once you solve prior auth.
Thank you so much. And yeah, if you are interested in performing some of this work and trying out pilots, please do let me know.
Sounds good. Take care, and thanks very much.
Aaron, I hope you could stay for the next 5. Can you stay for the next 5 to 10 minutes?
Unfortunately, I cannot. I've got to pick up someone from a medical appointment, but I appreciate you guys hosting me.
We'll give you a synopsis. That's fine. Thanks, Aaron. What we want to do next is take a look at some policy options to reduce low-value care. As always, we're going to want to listen carefully to what Katie's got to say, Katie Spangler. But I think given the issue that we just discussed on prior auth and some related issues, I want to kind of flip this, and if you don't mind, go to Mark Fendrick first. And I see he's already found something to put on the screen. That's quick, Mark. And then ask Katie to reflect accordingly. And I know Katie's got some input on some other policy initiatives underway. So Mark, let's turn to you first.
Thanks, Cliff. To be completely honest, I wanted to thank Aaron. He had to run, and I was going to tell him to thank 2 groups. One is to thank his parents for birthing him when they did, because as you know, Cliff, and many people on this call, that if it wasn't for Mike Chernew and the VBID Center board, low value care would not be where it is in the national discussion if it wasn't for them. And it was people like Aaron, he's not with us, that you're old enough, Cliff and Mike, to remember the discussion from The Graduate about, I've got one word to tell you, plastics. John Maffei and Ashani and Aaron, it was Mike largely, Gail Winsky and others, and maybe you pushing me, the carrot guy, to understand the importance of robbing low value care Peter to pay high value care Paul. So so I know he's gone, but if it wasn't for Mike and insisting that VBID have some cost neutrality, I'm not sure that a lot of this work would be able to come to the fore. So I'm just going to talk very briefly and let Katie close this out about how we could tie the previous discussion around prior auth that was general and I'd love to hear from some of the task force members about how we could tie prior auth to our work in low value care. So it's really interesting to me that you saw very clearly on Aaron's slide that it says that the burden of prior auth to Mark Friedberg and the Aetna folks and the Humana folks and all the others is the approvals. And I've always wondered as a clinician, why are my health plans putting prior auth in front of me in things for which evidence is strong? Why, if you look at the list of the high-ranking prior auths that Aaron shows in his work, these would not be on our low-value care list. And it's really interesting that some of you might remember Dean Smith, who was one of the very earliest value-based insurance design co-conceptualizer. When he was working for a health plan, he said they didn't put prior auth in place largely because the cost of the program was larger than the cost of the denials that they actually put, because they're, as you heard from Aaron, that their approval rate, meaning letting the prior auth go through, was so high. So in trying to kind of put together this entire conversation and being peripherally involved with some of the work that Aaron mentioned on legislation regarding the modernization of prior authorization, I really just wanted to say almost all of the conversation, including today, was about processes. Make them electronic, make them more accessible, have, as Denise said, an independent party, other types of things. And what I would like to hear from some of our payers that are still on the call is, why wouldn't we reframe prior auth, for which it was when it started in the late 1970s, was a way to hopefully protect patients, not hear them complain about delays and whatever else, from care that, as I say many times, at best doesn't help them and in many cases harm them. And as we put the whole today's discussion together, we've been measuring these things for a very long time. And Cliff, if you align the services for which we spend the most on low value care with align the number of prior auths or the money that's spent on prior auths or the number of prior auths, for some rare reason, these are not aligned, right? You'll often see very high cost drugs, which are expensive, but I don't think prior auth should put it in place to stop me from using high cost things that are some benefit. I think that as we reframe prior authorization with these new processes in place, that we would ultimately focus on those services that are used in a low value care setting quite often. And if you look at the Office of Inspector General report recently and kind of pushing back on certain types of plans and denying care, almost always those controversial cases are not about services that are likely to be no or low value. They often have many situations they're clinically valuable, which allows me, as I kind of wrapping down here, to the term, Cliff, that you've helped us with over many meetings called the waste index. So as all of you know, no service is ever high value or low value. And my three favorite high value services are also my three favorite low value services, depending on this term, a clinical nuance that you all know. But what we have done in our research and within the health waste calculator is create this term called the waste index, which is basically very simply the number of low value care uses of a service over the total number of those services. So the services that are often used in a very low value setting have a high waste index, and those that might be expensive but are often used quite commonly in a high value setting have a lower one. So in this health affairs piece, I basically argue that if this legislation were to go through, and like we heard from Mark Friedberg and gold carding and whatever else, we other processes in place, that maybe we take a much closer look at not how prior auths are processed, but what are the services that we're actually focusing prior authorization on? And I want to leave you, and I'm going to put in the chat when I turn this over to Katie. We have been doing a lot of work now with 7 all-player claims databases across the country. Some of you heard Michael Boudros's report on our 2nd volume last task force meeting. But we have quantified for each of those states services that have both high costs, which most of you payers care about, but also a high waste index. And the top 5 of those lists, a different top 5 list than what Cheryl Larson is always asking me to expand, is first, opioids and low back pain. Second, prostate cancer screening in men over the age of 70. Third, pre-op testing for low-risk patients for low-risk surgery. And PICC lines for patients, a certain type of invasive intravenous line for patients with chronic kidney disease. It should not surprise any of you as we get to the rubber meets the road at the end of these meetings about future directions, which I'll get to, and implementation, how hard this is, that 2 of those things are on Beth Bortz's list in Smarter Care Virginia. And the great struggle of our friends in the Washington Health Alliance, right? They picked opioids and low back pain to be the focus of their statewide implementation. So I am hopeful that all of this work will also extend to the prior authorization discussion. And I'm hopeful that some of you on the payer side may want to respond to my plea, which is typical of most of these meetings, but this meeting, it's a plea. What would you think about relooking at the services for which you are receiving most of your prior authorizations, and to see how often those tend to be on our low value care lists? So if it's okay with you, Cliff, if we have a little time to hear from the audience, if there's response, and then after that, feel free to turn it over to Katie.
Well, it's a fair enough question, Mark. And I think that those kinds of the lists of low value care, wasted care, and so forth aren't necessarily tied directly, haven't been formally, to what's on prior auth lists. And so it certainly would be worthwhile to explore how those 2 relate, and maybe making some adjustments along the way. I'm wondering if anybody wants to kind of raise their hand on that issue, or otherwise pipe up in response to Mark's query here.
So Carol, I'm not sure if you're still on the line, but I know you at Emblem are doing a lot of work around gold carding and prior auth. I'm just wondering if the low value care intersections have come up in your conversation at all, and if not, whether they might be.
Yeah, and I actually really love what you said about reframing that, Mark. And so I'll talk to Dr. Dow-Cole about that, because some of the reason why we have prior auth and there's a mechanical process is because you're trying to get clinicals, right? So what we've found is when we get access to EMRs, some of that goes away. So there's a bucket there. Some of it is around trusting your provider partners because you have a value-based agreement. And so we've gold carded in certain circumstances, around there. And when I just kind of went through the list, the 5 that you mentioned, we have, I'll say, clinical strategies around opioids, low back pain, each of those really we have a clinical strategy around, but I don't know whether I've really tied it back to the prior auth process intentionally. So I really like the way you're challenging us to do that. But I think in the future, some of these problems will be minimized as more value-based contracts come online, as we have technologies coming online like the Epic payer platform. AI certainly is in the forefront around this, but it's also trust. And so one thing that we've done through Dr. Dow-Cole's direction is it's like you give the provider group your phone number, and they know who to call. It's phone a friend, because sometimes, we're seeing the issues are around a complicated policy or something that's just not human, and so I say a lot about being human lately, but it's just like sometimes we've lost through all these processes, and I'm a process improvement I'm known for it. I'm a process improvement person, but sometimes we get too caught up in the processes and we forget about how to have those human touches that sometimes, you just have to ask, like, what would you do instead? What would make it easier on you? And so I think that as we move forward, again, I think that we're evolving to be smarter and to work together more, because the system has to work together more. Otherwise, it will completely fall apart. And so I think that we're going to take these concepts, and I love what you said, Mark, because we're going to take this concept and reframe it to, we're doing this to spend the healthcare dollar wisely, and so let's have a different conversation in the future. So thank you for this.
Yeah, and to the extent that you can link well-recognized sets of low-value care services to prior auth, it might even lend greater credibility to prior auth. We're doing this for a good reason. We're trying to avoid harm.
Yeah.
We're trying to avoid unnecessary services. It's not just about saving. So
yeah.
I do want to commend folks, by the way, to Dot's point about that trade-off between high volume, low value care services. But with the cost issue, it might cost more to kind of walk through the prior auth process than what you'd save for those services. But in any case, with no further ado, I definitely want to go over to Katie Spangler. Katie, I know that there could be a considerable list of things to run through for us, but please give us the highlights of these set of policy options and other things cooking. It'll give us a very useful update. Over to you, Katie.
Yeah, thanks, Cliff. And Carol, I think that was a great segue of your mention of trying to make care smarter. So there is actually a coalition in DC called the Smarter Healthcare Coalition. You guys have heard from me before, but we are kind of a policy arm focused on value-based design. We had been really focused on making it easier for patients to get high-value care by working with policymakers within Congress and the administration. And then more recently, we have expanded that focus to also look at low-value care. And so I put a link in the chat to a letter that the coalition sent to Secretary Becerra. I will say I feel really positive about where we are in discussing these concepts with the administration. We've had some really valuable calls with the CMMI team on low value care. So I'll focus a little bit on our kind of administrative push, and then I'll also mention that we are also talking to members of Congress and their staff about a legislative push. But first, I'll talk more about the administration. So as you can see in the letter, we really focus on 3 policy areas. So one policy area is encouraging the Secretary to utilize the authority that was granted as part of the Affordable Care Act, specifically Section 4105, that grants the Secretary the ability to no longer cover D-rated services by the U.S. Preventive Services Task Force in Medicare. So to date, as far as I'm aware, I have not seen that flexibility utilized, but that's something we would certainly like to see. I know cataract removal has come up as part of this conversation. So right now, as you guys know, there's a lot of pre-op before cataract surgeries. And so that's one area where the previous administration was really engaged. And we've also been in conversations with the current administration about that. So just in general, that first recommendation is to encourage the Secretary to utilize that existing flexibility. The next recommendation that we outline in this letter is the notion of, through the CMMI, or the Centers for Medicare and Medicaid Innovation, working through the Medicare Advantage demonstration program to allow MA plans to no longer cover those low value services. So that was our second recommendation. And then our third was to work more collaboratively with CMMI on some type of a multi-payer, multi-state demonstration program that would address some of the concerns that we've heard from earlier speakers about different payers asking different things of different providers, and wouldn't it be great, at least with regard to low value care, if we could standardize that a little bit more? And so the thought there is, could we structure some type of a CMMI program where you have payers working together through Medicare, Medicaid, as well as the large commercial plans in that state or the employers in that state to really discourage low value care. So there's an example that some folks have likely heard me speak about in the past. But in South Carolina, for example, they saw the data on early elective and inductions before 38 weeks gestational age. They saw how bad that was for moms, how bad it was for babies, and the large health plan and the Medicaid plan and the Medicaid director got together. They covered about 80% of all births in the state of South Carolina, and they got together with the hospital association and they said, hey, we're not going to cover this anymore. It's bad for the moms, it's bad for the babies, and we're not going to cover it. And almost overnight, the rate of early elective inductions of C-sections plummeted. And so it really was, it's a great success story. We'd love to see more things like that as a way to try to make it easier on the providers. Switching, so that's our work that we are doing with the administration. And we have also had a legislative focus as well. I will say that sometimes when you're talking about large entitlement reforms or changes to the Medicare program, those things I'll say quote unquote are easier when you have a split Congress or split administration in Congress. So depending on what happens in the election, I think the thought is that maybe there would be an opportunity to do something next year that would need to be bipartisan. I think, you know, it's very uncommon that you would see major entitlement reforms occur when one party has both the House, the Senate, or all three of the House, Senate, and the White House. And so depending on what happens in the election, if we do have split control, that might be an opportunity to do something in this CMMI space, or even something, you know, more recently, some folks have been talking about amending Section 4105 of the Affordable Care Act. Right now, the verbiage is a may, meaning that the Secretary of Health and Human Services may allow Medicare to no longer cover D-rated services. And so there's discussion about maybe changing that to a shall. And so the Secretary of Health and Human Services would be required to stop covering D-rated services. I realize that might cause some folks some consternation, but the idea there would be to get just more aggressive in this space from a Medicare payment standpoint.
Hey, Katie, before you go on, you referred a moment ago, a couple of times to advantages of a split Congress versus not. There's a little subtlety there. Could you just kind of go back and it's a kind of counterintuitive. Why is that the case, Katie?
Yeah, so what I mean by that is if Republicans take the House or the Senate or both, but if they take one and then you have the other, the Democrats are still in control of the other and the Democrats are still in control of the White House. To your point, it's not super intuitive, but it creates a little bit of air cover. So Democrats, for example, are in charge of the White House, the House and the Senate, and something happens on entitlement reform and you're taking benefits away, even if it's a low value vitamin D screening benefit, anytime you're taking benefits away, you're not a popular person at all. And so usually when those types of things advance, it's only through bipartisan support. And so Democrats don't declare war on Republicans over it, and Republicans don't declare war on Democrats over it. And there's kind of a, hey, this is for the greater good. It's for the long-term solvency of the Medicare program. We realize like we're probably going to get heat from some of our constituencies over this, but as long as we're working together on it, you increase the chances of it happening.
Thank you for that insight.
Yeah.
Very helpful.
And it looks like, yeah. No, sorry, I was
Lloyd,
just going to say, it looks like Lloyd has a question. I'm happy to jump in on that now.
Yeah, Lloyd, what's your question?
Was actually just to kind of add on to your comment. I'm from South Carolina. I work for Blue Cross Blue Shield of South Carolina, and part of the Birth Outcomes Initiative, which actually implemented the early elective C-sections, as well as went on ahead and did any elective vaginal deliveries that were pre 38 weeks as elective. So we and what the way it was organized, it was through our Birth Outcomes Initiative, which brings together providers, payers, Blue Cross Blue Shield, our Medicaid MCOs, as well as the hospital associations and the hospital facilities, and we were able to come together and come to an agreement on how to limit and decrease these early elective C-sections and early elective vaginal deliveries, and have been very successful. And it's expanded in terms of how we've dealt with just different hospital emergencies, making sure quality care is met, looking at like maternal hemorrhage, maternal blood pressure, diabetes, and so forth. And it's really expanded from there in terms of like dealing with gestational diabetes and making sure we at Blue Cross have implemented a plan to provide insulin at low or no cost for certain members that meet certain quality metrics and so forth. So it's just really kind of expanded from there. And I just wanted to kind of add comments on that.
Thank you very much, Lloyd. Good gosh, anything for maternal and child health. And I know that some of the folks among your beneficiaries are, some of them are experiencing disparities along those lines. So all to the good. Thank you. Katie, back to you.
No, I thank you, Lloyd. I would love to chat sometime soon. I'm sure we can connect. That, Cliff, that was kind of the Cliff Notes of what the coalition has been up to, kind of what our vision is for next Congress, but just really appreciate the expertise of this group.
Not going to let you off the hook just yet, Katie. Since you've been doing this for a while, and we always appreciate your perspectives, can you just kind of step back and kind of go up 10 or 20,000 feet and tell us, given the political situation, and you touched on that already, and maybe perhaps coming out of the pandemic, what is the political appetite for the kinds of changes that we've been discussing all day today? I mean, I know there's kind of a potpourri of things, but are the decision makers, the policymakers, more or less amenable to trying to take a hard focus on reducing low value care services and improving high value care services? What's the current kind of gestalt there?
Yeah, so Cliff, I have been nodding my head vigorously as I've been listening to this conversation. Also, Jeff Levenshirt's, your comments in the chat about, healthcare inflation. We haven't really seen it yet, to your point about the 3-year contract cycle, but it is coming and it is going to be ugly. And so I worry that the feds aren't going to have much of a choice but to look at entitlement. I mean, and entitlement program spending too, it also just, it's going to increase, especially with interest rates going up. And so I think they're going to have to do something. I think it's going to be pretty sobering. And so I would love to be at the ready with recommendations that are actually better for patients, that can save money and that can make care smarter. It seems like a win-win-win to me. And so I do think that there's going to be an appetite to do some of these things. I mean, you saw the House pass the prior auth bill, or the committees. And so, there is momentum here, and there's talk about it. Not to say it's going to be easy. I have scars from some of these fights, deep scars from some of these fights. But I think something's got to give.
So the inflation hammer, maybe we can redirect the inflation hammer to something actually more productive. If you really are trying to save here in these high inflationary times, there's a way to do it that regards patients and actually gets rid of harmful stuff and promotes the good stuff. So that focus may actually be in our favor here. But in any case, Katie, as always, we appreciate your insights, and you never don't say something I haven't heard before. You always say something new and provide some very helpful insights. So we always appreciate it. Thank you so much.
My pleasure, Cliff. Thanks.
Okay. What I'd like to do now is want to go to Chernu next. And Mike, I know that I'll give you kind of two things if you don't mind. One is I know you've got some thanks that you want to offer to folks, but Mike, do you have any sort of wraparound comments based on what you've heard thus far today? I know you had a few comments along the way, but do you have any kind of big picture findings or anything that somebody should have said that missed, or something you really want to emphasize? Mike?
Well, I think a lot was said. I won't rehash it. I was excited, I mentioned at the beginning, for this lineup of speakers, and they exceeded my expectations. So I want to thank Katie, Mark, Will, and Aaron, some of them in absentia. But I think it really was a remarkable bit of information that was conveyed from both the actionable policy, actionable managerial things to bigger policy discussions. I think what we've been sort of struggling with, or maybe struggling is the wrong word, grappling with as we've done this, is there's never a constituency for low value care, but figuring out whose responsibility is it to remove it, and who holds the fiscal bag when it's delivered remains a challenge. And the thing that strikes me from these discussions, and from the fact the folks that are here, is just how we in the United States deal with the fragmentation of the healthcare system. So I think we have a great multi-stakeholder group here, which I'm thrilled about, but I think that just emphasizes success is going to require action by a great multi-stakeholder group. So there's a few things I think we can emphasize more going forward, particularly around measurement and how measurement can help people get to the same page. I think there are a lot of discussions here about information flows, which is slightly different than measurement, but how does the right information get to the right people at the right time? And obviously things of incentives, but I won't dwell on that. I think I will just, for now, say thank you to all of the sponsors, Johnson & Johnson, Merck, and Pharma. It really is important to us and rewarding for us to continue these meetings and to see what great attendance we get. I wish we could all meet in person, although I have to say doing it virtual allows a broader set of stakeholders to attend. But in any case, the support is really appreciated. And I think if you look at the fingerprints, particularly Mark's, and on the activities that are going on, you will see that I feel we've been actually pretty successful in what we've set out to do, not to say that there's not a long way to go. So Mark, you may want to give some further thanks to everybody, but I really enjoyed the day and really do appreciate the time you all spent with us. And please do send feedback, comments, questions to us or to anyone else that you've seen or heard at the meeting. I think it's a group of people that really are passionate about trying to make the American healthcare system perform better for both the patients and the payers and the purchasers and the providers for that matter. So again, thank you all, and please don't hesitate to reach out.
Thanks, Mike. Over to Mike. Thank you very much.
So of course, Michael, I would like to thank you for being such an amazing partner. And for those of us who can get up and give a standing ovation, once again, Cliff, these hours go by so quickly. I learned so much, and you're just like an amazing orchestral conductor, which you know means a lot to me. So for those of you who remain, I have to tell you that I don't know of any meeting that I've been to 12 times in a row. And as I text Mike throughout these meetings, is that I would come to this, whether I was an attendee, a speaker, if I was lucky enough to be able to advance the slides. And thinking about moving forward, first and foremost, you'll all be receiving emails from Susan, Lynn, and Jordan, but we have set the date for the spring meeting. Thank you for some of the sponsors who've already stepped up to make sure that the task force will move forward. It will be on April 20th, 2023 at the same time. We have to make some decisions, and we'd like to hear from you actually about whether we continue this virtual meeting or we decide maybe once a year or not at all to meet in Detroit again in the Airport Westin. But the date of the meeting is set. Whether it's in person or virtual remains to be seen. Would like to hear from you about that. I just think in closing, I think about, and Mike, you know, and I lamented this, there was a very, very critical perspective in the New England Journal about the Choosing Wisely program. Saying so much so that the author actually said we were probably worse off that it happened compared to not. And my colleagues and I wrote a letter to the New England Journal that was published talking about how unbelievable Choosing Wisely it was to be able to provide some infrastructure, funding, organization, and of course, those many, many lists of low value services that actually allowed this agenda to move almost the exact same period of time as we in the VBID world have been working on low value care, about 6 or 7 years now. And although, as Will pointed out, in the decade between Don Berwick's article and his in JAMA, there had not been great progress in terms of reducing low value care for those of us who measure it, which was their primary criticism. But I wrote in that letter that I felt that the Choosing Wisely initiative and all of this work around low value care right now should be deemed as a successful failure, which was a term used by an astronaut on the Apollo 13 mission here from the University of Michigan. The momentum is growing. You're just seeing more and more inroads and discussions and projects and actually really serious implementations, two of which we like to highlight in the Commonwealth of Virginia and the great state of Washington. So I remain, as always, the Tigger out of Mike and I in the 100-acre wood, very, very positive that given, as people tell us, how much money there is in low value care, more so than what we spend on education, is that what we heard today? That we hopefully could continue to chip at these services so we can in fact rob low value care Peter to pay high value care Paul. So Mike and I really want to hear from you between now and April 20th. The last thanks and probably the most important thanks to these meetings get together go to Susan Lynn Osterly and Jordan Clark, who are behind the scenes making sure that everything go as smoothly as they do. And I want to thank you for giving me 7 minutes back so I could watch my Phillies, who were in the wild card game, Beth Bortz against the Cardinals, still 0-0 in the top of the 6th, I believe. So with that, Cliff, I'll let you adjourn the meeting. Want to thank you all. You see our contact information on this slide and are super excited to see all of you in April and hopefully maybe even before that.
Thank you so much, Mark. It's great to hear from you and Mike. Wrapping this up, and great regards to Susan Lynn and Jordan, of course. People love coming into this meeting because they hear the real world prospects of how this is actually working out. We came here with a kind of a shared set of principles, but we hear every single time how things are going, what the lessons learned are, what are the upsides, what are the downsides, what are the next policy alternatives. We always feel like we're right in the mix of this. And for that, great thanks to everyone. We'll see you next time, April 20th. We'll be here before you know it. Take care, everybody. Bye-bye.